Good morning. We welcome you all to the 4th edition of the Nursing Conclave. This year, our theme is From Assessment to Healing, Nursing Leadership in Wound Care. I request the dignitaries to please be on the dais. Mrs. Dolly Bishash, Co-Chairperson, National Health Committee, the Bengal Chamber of Commerce and Industry, and Chief Nursing Officer, Fortis Hospital, Anandapur. Ma'am, please be on the dais. I request our chief guest of today, Dr. Shopon Soren, Director of Health Services, Government of West Bengal, to please be on the dais. Our guest of honor, Ms. Abanti Gopan, Nursing Consultant, Clinical Services and Education. Ma'am, please join us. I now request Captain Madhukuri Ray, Regional Director Nursing East from Apollo Hospitals, to please be on the dais. Mr. Abhijit Mojumdar, the Chairperson of the National Health Committee, is unable to join today. He has informed in the morning due to some medical emergency in the family. So I request our co-chairperson, Mrs. Dolly Bishash, to please deliver the welcome address along with the theme and take the session forward.
Thank you, Sharbani. It is an honor and immense pleasure to welcome all the delegates over here for the 4th edition of Bbc&I Nursing Conclave. This year, we have chosen the theme, Assessment to Healing, Nursing Leadership in Wound Management. I am delighted to welcome our chief guest, Dr. Shopon Soren. Sir is our Director of Health Service, Government of West Bengal. Our guest of honor, Madam Abanti Gopan. Everyone knows Madam is the nursing consultant, the ex-director of Sikabela Group, and principal assessor of National Accreditation Board of Hospital and Healthcare Provider. Our guest of honor and special guest, Captain Madhukari Ray. Captain Madhukari, the director of Apollo Group of Hospital in Eastern Zone. And my dear delegates, all the distinguished speaker, chairperson, co-chair, and the observer from West Bengal Nursing Council today with us. Many students are going to attend the conclave today, the masters, the BSc nursing students over here. So my hearty welcome to one and all present in this Augustus gathering and in this morning today. Why we have chosen the theme, Assessment to Healing, the Nursing Leadership in Wound Management. The true healing starts right from the assessment part, where a meticulous observation by the nursing professionals are very much important. When an expert clinicians are working with us, Dr. Tivar, welcome you for this conference, sir. When an expert clinicians are working with us, they expect each nurses must have the thorough knowledge while assessing the wound and providing the treatment or meticulously following the clinician's order by understanding the rationale behind the introductions of the therapies or the dressing that is required for true healing of the patient. None of the people in this world will be happy to have a scar formation or a keloid formation or a marks that remains on the skin while a wound gets healed. Everyone wants that the skin should look like normal even if a person gets injuries on the skin. So, by understanding the modern technological advancement, the overwhelming use of the cutting edge technologies, which will bring and efficient wound assessment to wound healing. Today's world are based on the evidence-based practices. As a nursing professionals or as a healthcare provider, we must imply all these evidence-based practices which are there in front of us. A nurse must understand which wounds require a collagen therapy or a pectin or a gelatin or a wound managers which are required to be used for a patient. So understanding all those technological advancement alongside with the clinician, pivotal for the nurses for the healing or for early recovery of the patient. Today, nursing leaders, those who are working in this healthcare organization, are attending the conclave today, must empower every day to their nursing fraternity, those who are working, must take up the various specializations program which will prepare the nurses to stand in front of the patients with the clinician to have a deeper understanding of the healing process of wound. There are numerous designations which are coming in front of us, like an ostomy specialist nurse, tissue viability nurse, wound care specialist nurse. They are undergoing the specialization program to take up all those positions which are created by the nursing leader in the organization. If we find that the nursing leader finds that there is somewhere a gap is present, then you must take the forward step to request or to engage the specialist, the clinician, those who are having a great knowledge along with the nursing fraternity to enrich them with the understanding of the healing process. I congratulate Bengal Chamber of Commerce and Industry, who is organizing nursing conclave since last 4 years. And every year we choose the topic which are actually meeting a particular need of this specialty, by keeping in mind that if we are selecting a particular specialty, the number of nurses, those who are present in this hall, in this auditorium, will get a great knowledge or immense understanding of the scientific principle behind that particular specialty. So keeping in mind, I truly congratulate BCCI for giving the opportunity to the entire nursing fraternity to attend this conclave today. And I would request the audience to give a big hand for the BCCI for organizing this mind-blowing conclave. This conclave will have the plenary sessions, the scientific session, sensitizing session, and also we have organized a moot court today to make them understand if nurses are not mindful while caring, assessing the patient, understanding the interventions and providing the therapies to the patients, as well as an important part of the nursing care is the documentation. If we fail somewhere, we, even the patient relative can sue and the nurse will be pulled to the court. So that's all with this. We have prepared a moot court. I hope that you will be enjoying throughout when the session will start. And we have today also the quality improvement project presentation. We have paper presentations along with the plenary session. And in the second half or later half, we have also kept the skillathon where nurses will do hands-on practice to understand why these particular dressings to be needed or to be used. So you can ask, you can clarify your doubts that are there still within you, so that our patient will be getting care in safe hand. while we are carrying the wound, every time we have to remember a practice of asepsis and a practice of hand hygiene. That's the most important part while we are handling the patient wound and doing the dressing and the fundamental principle. So today our industry partners are with us along with this BCCI who has organized the conclave and the all resource person, those who are the observer, the delegates, the chief guest and guest of honor. I hope that the conference will have a mind-blowing experience and congratulations to each and everyone. Gurveer sir, thank you for joining with us and all the nursing leaders, the nursing in charges, MSc nursing students and all the faculties, those who are here with us today. Thank you very much and once again my hearty welcome to all of you. BCCI is not only organizing nursing conclave, but they have organized many other health conclave, the quiz competitions. They are organizing the summit of, I think from the Bangladesh and medical insurance conclave. So I truly congratulate BCCI for giving the opportunity for organizing such a good conclave and giving opportunities to attend. Thank you very much. Once again, welcome to all of you. Thank you.
Thank you, ma'am. I now request our chief guest, Dr. Shopon Sharan, Director of Health Services, Government of West Bengal, to please address us.
Good morning. It is really a pleasure to be here in this 4th edition of Nursing Conclave with the theme From Assessment to Healing, Nursing Leadership in the Wound Care. Thank you, ma'am, Madam Dolly, Madam Avanti Gupan and Madhukuri Rai. I hope this conclave will be recorded and with some edit, maybe it in this YouTube, so that who can't join physically can have this essence from their virtual mode. I'm going through this schedule. It is a really great one. Every aspect of wound healing is taken care of. And I believe I used to say in every forum, other than the armed force, the most disciplined cadre in the civilian are the nursing cadre. Can we have a clap for them? And as you know, from the very beginning of the definition of the health is a state of complete physical, mental and social well-being. So there is so many components in the health. Regarding the wound care, whenever anyone comes in the facilities, healthcare facilities, with the expectation they will be dealt psychologically, empathically, and with their knowledge, with their skill they acquired, so that whatever pain they have, that can be minimized at the first instance. I request all the dignitaries, the nursing leaders, let's have a try when we will provide the services, any kind of wound, all is wound. Physically, illness is also a wound, physical wound is also a wound. So, to address this wound, first of all, your attitudes towards the patient is very much essential. And with my request, some of the facilities can made it possible during the health providing time, they are away from the virtual modes. So, if we can change this minimum, that during giving the care, we are not engaging ourselves with this virtual world. We are in the real world, in the ground situation, and our attitudes make them assured, relieved that our nursing professionals are empathetic enough, they are skilled enough, they are knowledgeable enough, and they used to talk. Somewhere, though said it is a disciplined community, somewhere I used to travel throughout the state as a virtue of my chair, starting from the Darjeeling to Purulia, to Gosawa, to any zone, difficult zone. Somewhere there is some lack that we are not that responsive. And we are very much engaged with our documentation without doing the proper response in due time. I request the team leaders who are here, the students, the professionals, please show your response that patient immediately feels that I am taken care of. And that feelings only comes when you own the system. This is my system. I have to make proud of my system, and I also be proud of my services. And you will assess all these things. I am going through the details of the schedule. It is nicely composed. Starting from this, in the last part, the prepare presentation, all kinds of issues are incorporated. But my just request, whatever paper you will do, whatever thesis you will do, if you not implement and your attitudes doesn't reflect that you are really caring. Coming to this conclave, I'm thinking of, I used to, for last years, I have attended so many lamp lightings, so many inauguration of the nursing system. And whenever they used to say that great lady of Florence Nightingale, who used to find the wound the soldiers used to have with these lanterns. So, she can have a life of a luxurious life. As you know, I think all of you have gone through her life. If till now no one have gone through her life, you have just listened it, please, gone through her life. That will motivate you to serve your profession, increase your prestige, increase your honor. And in the last, what I want to see, whenever you leave a healthcare facility, the peoples who get benefited will give you the farewell with the tears. That will be the success of this profession. I think we have to change our some attitudes, work activities away from the virtual media. That is really distracting. I am going through this so many in my government health facilities. There are so many chaoses occurring. The complaint is our nursing is engaged herself in a virtual mode, delaying in providing care. So I think just keep up your virtual mode equipments, and what one of my facilities had done is nicely. You have a family, you have a children, you have brother and sisters. They may be in danger when you are in service. So a facility can be made with a common number so that any emergencies come, you can't receive, it can be received by the authorities and communicated to you so that you can respond. So you will be not in worried situation, what is happening to me. Because we are habituated in calling every 15 minutes, texting every 10 minutes. I think when there was no virtual modes, we used to write letters. It will reach when all is finished. We have beared it. I don't be so harsh, but if you do a common systems of addressing where communication can be made by the relatives and friends, and in emergency that can be communicated, so that you will be jolly well serve the patients without worrying of your near relatives. And I really thanks BCCI for taking such a innovative initiative in respect of disseminating the modern advance in the nursing system, specialties in the nursing system. There is scopes has been opened, widened. There need a CCU nursing, there need a dialysis nursing, there needs a wound care nursing, there needs the fast show. And one of my requests, now somewhere in the private sector, I don't know, somewhere in the public sector, they refuse to do multitasking. In the modern era, we have to digitalize ourselves. It is nothing wrong, because you have to cope up with the advancement. If you engage throughout your day with writing so many of documents, definitely there will be a delay or unintentional negligence to the service. Hope this nursing conclave will be a great one. All will get knowledge, and from the next very day, what you can't do, please try to implement it. Just own it. Everywhere there is written, Amar Balobasar, Amar. So, we can own it. This is my two-thirds of the time I spend here. This is more than my family, more than my home. So why can't I own it? Owned it, loved it, share the love, share your skill, knowledge, attitudes towards the persons who are coming from relieved any kinds of wound pain. Can be a psychological, can be a physical. With these words, again I thanks all the team leaders, and with my great belief, my disciplined cadres in the nursing, they will be disciplined, they will be more diligent in providing their service. Thank you all.
Thank you, sir. I request Avanti ma'am, our guest of honor today, to please address us.
Esteemed dignitaries on the dais, dignitaries of the dais, my friends and colleagues, and many students. First of all, congratulations to BCCI and especially the convener Dolly Biswas for organizing such a wonderful conclave, especially for nursing, a full day dedicated for that. And I must thank Dolly, even though as a fill-in last minute, but thank you for inviting me to be here. It's my privilege to be here. And as I get an opportunity also to do some updating of my knowledge. Incidentally, June 1976, exactly 50 years ago, I graduated. So this is my half a century in the profession. So it's, thank you. So it's really a good time for me to keep updating and learning what's happening in the world today. Now coming to the theme that you have selected, wound assessment to healing. Assessments are done by nurses and assessments in great details. Now I have seen that there are many new tools available for assessment, like the time tool, or you have the UK NICE guidelines, they have come up with a tool. There is a WHO tool for assessment which asks that you should take a photograph of the wound and follow up with the photographs as part of documentation. I don't know whether that is being implemented anywhere. Oh, that's very good. So that's a graded WHO tool. Then there is your National Wound Care Strategical Program, also by UK. So these are many new tools which are available. AI assisted tool that is digital, that is also very good, because when you feed in the photograph and when you feed in that information, AI gives a very precise and accurate algorithm as how to manage the wound. All that is fine. But my reflection is, as I have wandered and visited a large number of hospitals all over the country by virtue of being an NABH assessor, how many hospitals and how many surgeons allow nurses to do the surgical dressing wounds? Most of the places I have found that they are not permitted to do the dressing. As I said, 50 years ago, we used to do the surgical dressings. Our teachers used to do, the staffs used to do, as students we used to do. During my career, some years ago in Mangalore, I was supervising a senior nursing student who was performing a complicated wound dressing. And she was competent, which is why she was doing it, and I was with her. But the consultant came and made a hue and cry about the whole incident as to why and who had permitted her to do the dressing. This I found in most places, that the consultants have their personal dresser, who may not be a professionally trained nurse or a doctor, but maybe by virtue of experience, they have become competent in doing dressings. Even for follow-up home care, these persons are sent to do the dressing. So when you, sir, talked about discipline, it's very good that we are a very disciplined profession and it is needed. Have we over-disciplined ourselves, that we have stopped questioning? we have stopped demanding? Have we become like in the army, but to do and die, not to reason why? I request all the eminent nursing leaders present over here, many of whom I have had the privilege of working with and the honor to see them shining and leading today. Please reflect on these aspects. Why do we need empowerment when by virtue of our credentials, we are privileged to do these things? Where have we lost the confidence of our healthcare partners, of the medical professionals? Why are we not allowed to perform these procedures, which is our privilege? I think there are few surgeons present over here, and maybe during the day some others would join. So these are questions I would like to reflect upon and find answers, so that it's not just assessment, but assessment to healing. And healing will take place when we do the dressings ourselves. Evidence has shown, researches have been done, and it has been shown that surgical site infections are 45% less when performed by nurses. Because of the very fact that we are disciplined, we follow the protocol to the T, and we don't try to overcome the steps of the procedure. Another research has also shown that when with seniority you become competent, you become self-confident, you tend to skip some of the steps and maybe compromise. But when novice nurses are very particular to follow the steps so that they should not go wrong. So these are some aspects. And as you said, implementation of research findings, evidence-based practice. Where is the scope for implementation when they are not permitted to do most of the things which they are privileged and they have become competent to do? So these, especially I'm talking about the private sector, having worked in the private sector most of the time. I don't know about the government. Perhaps they are doing a few more things, but then the nurse-patient ratio in the government is appalling. So I don't know where they would get time to do these things. So these are some of my reflections, some of the thoughts that were flooding through my mind while I was listening to you all and while I have gone through the program also. So I hope during the day these things would be addressed, and later on when you will go back to your workplaces, you would be able to implement these. And talking about empathy, I have personally seen a very eminent late nurse leader who was in our hospital, had an infected and gaping wound. And while the dressing was being done, there were tears rolling through her eyes. And the nurse who accompanied her was so empathetic that just the way she touched and comforted the person, later on she gave me the feedback that this kind of a feather touch nursing is the reason why I chose to come to this hospital. So this kind of rewards are what we are looking for. But apart from empathy, let us be privileged, let us be empowered to use our knowledge, our competence, our skill into practice. With these thoughts, I would like to again congratulate the team for organizing such a conclave. Thank you very much.
Thank you, ma'am. I now request our another guest of today, Captain Madhukari Ray, Regional Director, Nursing East from Apollo Hospitals, to please address us.
Good morning everyone, the guests that on the dais and off the dais. I am really privileged to be here and honored that amongst such gathering that I am getting a chance to talk and to stand in front of BCCI. My heartfelt thanks to BCCI for arranging such conclave year on year. This is the fourth one in the row. So this is very nice for us to think, to put together everyone. As Dr. Soren said, very nice that nurses are expected to do a lot of things. Madam said that there are a lot of evidences, lot of examples are there that we have good nurses in the system who can make difference every day. But it is important for us also to understand, today if Bengal Chamber of Commerce is thinking of wound therapy, is wound management is a challenge for nurses? Are we all agreeing to this? That wound management still remains a challenge for all of us? Yes, it is a challenge still. Despite having the knowledge, despite having skills, development programs, and attaining skills, despite having AI-generated tools available with us, and all the facilities available with us, we have clinicians beside us to always guide us for the wound management. And we ourselves have good knowledge about wound management. We talk about different tools, we talk about different methods for the wound management, including push tool and so on and so forth, as Madam also mentioned. But to the healthcare leadership, and sir, to you also, my request is that I feel we nurses want to put our best foot forward. Only one place where we have challenge, we do not have good number of nurses as per the demand, where we should look into that even if we want to do our best, whether we are given that environment to do the best. So there I want the nursing leaders to speak up, to take up the challenge forward, not only for the number of nurses, but build confidence and build skilled nurses in the system, have a smart principle to apply every day so that we can make difference and we can do the things the way the system demands. That is very important for us. With that, I once again thank the BCCI, and I also feel that today's conclave is going to give lot of learning for all of us. Make use of this platform so that we can make difference every day at bedside. We can empower our bedside nurses to learn and to take the clinical decisions at every moment, that what type of wound it is, what type of management is required, and what type of prevention is better than cure. I always say, everyone, we know that prevention is better than cure. So how can we prevent wound development so that we can have the least need for management? So that is, with that note, I thank once again everybody present here, and BCCI especially for having this conclave done. Thank you.
I now request the dignitaries to please join for the lamp lighting and inaugurate the program formally. I also request the observer madams, Ms. Madhuri Manna and Ms. Ashmita Mukherjee, to please join, and also Dr. Akhilesh Kumar Agarwal and Dr. Tibar Banerjee to please join the lamp lighting ceremony.
या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युत शङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा।
I request the dignitaries to please be on the dais once again. We will now release the conclave souvenir. Thank you. This souvenir is now also available on the website. You can log in to the Bengal Chamber page, and there is a nursing page also. We have one more task to perform. We would like to felicitate sir. I request our co-chairperson to please present a memento to Dr. Shapon Soren, our chief guest, on behalf of the Bengal Chamber. Sorry. I also now request our co-chairperson to please present a memento to Avanti ma'am on behalf of the Bengal Chamber. Thank you. We will now take a break for 5-10 minutes for the changeover to the plenary session.
কার আছে তোমরা বলে দেবো লোড হতে দাও কাটলা কেন ঠিক আছে
সকালবেলা আসেনি ঠিক আছে হ্যাঁ
Good morning, ladies and gentlemen. I'm Ondrila Acharji. With me, I have Ms. Sunita Kumari as my co-host. So we are taking this event to our next session, plenary session 1. So we welcome Captain Madhukari Ray ma'am as a chairperson of this plenary session and Ms. Manashi Bhaskar ma'am, Chief of Nursing, Peerless Hospital. I welcome Manashi ma'am and Madhukari ma'am to please be on the dais. For this plenary session, we have our first speaker is Dr. Tibar Bandopadhyay, Plastic Surgery Department at Fortis Hospital, Anandapur, presenting on updates on wound healing, identifying and managing chronic wound versus acute wounds, and breaking common wound care myths.
Our next speaker is Madam Polomi Roy Chaudhary, Senior General Manager Nursing at Charnock Hospital. Madam will be highlighting today the risk assessment and early detection to prevent worsening and complication of wound.
Next, we have with us Madam Jessie Saji Varghese, Head of Nursing, HCG Cancer Hospital, Kolkata. Madam will enlighten us today with the consequences, prevention and management of burn injuries in hospital settings.
Presentation.
Our another speaker, Dr. Akhilesh Kumar Agarwal, will be joining us shortly. He is on the way. So now I am handing over the dais to Madam Madhukari Ray ma'am.
Once again, good morning to all of you. So now we start with the scientific sessions, and this is a plenary session 1, where we have the clinicians with us. Both of them, Dr. Tibar and Dr. Akhilesh, definitely are going to give us the current and updated version of wound management, and I'm sure that we will be having some new things to learn. And our plenary session theme is going to be on the bridging the gap in wound assessment and going forward as effective management that is required. So in absence of Dr. Akhilesh, I would request Dr. Tibar Banerjee, who is a consultant of plastic surgery, Fortis Hospital, Anandapur, to talk about updates on wound healing, identifying and managing chronic versus acute wounds, breaking common wound care myths, which all of us have to learn that common wound care myths, what we have in our mind. Today we want to have a better clarity to understand and do the wound assessment as appropriately and then the management consecutively. So over to Dr. Tibar Banerjee, please.
Good morning, everybody. I'm not used to speak in a gathering as a first speaker. As a student, we always came last and always wanted to slip out of the gathering. Still, presentation. Where's the presentation? Achha. While they start all these things, let me take my time. I have been working in an Apex government hospital as well as an Apex private hospital for almost 25 years or more. So I was listening to what Avanti Madam was telling in her inaugural speech. At least I found nursing in a government hospital and nursing in a good private hospital, I'm not talking of the moderate below par nursing homes, they're two different universes. There is nothing to compare, nothing. There are good nurses in both setups, no doubt about it. They are very dedicated. They are very dedicated nursing professional in both setups. But in a government setup, managing wound care for a nursing person is almost impossible with their pressure load. In a private setup, yes, they can definitely do it. And as Madam has said, I'll rather have my faith on a newcomer or a person, a novice girl, rather than a experienced sister, because novice or the newcomer follow the rules to the toe, which always, even, I've started before you, Achilles, sorry. So that's the basic difference between a private healthcare and a government healthcare. It needs to be changed, I agree, because there are a lot of pressure on a private and a government healthcare nurses also. But wound care, at present, I do not think if Dr. Soren would have been there, would have been much better. But I don't think that has become a private. That's a primary necessity. We know what happens in the peripheral hospitals, government hospitals, particularly if somebody with burns get admitted. The condition is surely pathetic. All said and done, let's discuss some theoretical problems, theoretical issues, and then we'll again come to the practical things. Thank you. So for this presentation, my student Komal has helped me a lot, but let's go with the updates. So it's more a theoretical discussion why this healing matters, because the clinical burden, it's a huge burden to all to society. The increases incidence, increases incidence due to diabetes. We all know diabetic foot ulcers, the aging populations, because people are living quite long and they are prone to more and more wounds. Vascular diseases are getting diagnosed more, and of course trauma and burns. I have agreed, Dr. Achilles also would agree that the trauma, particularly the road traffic accidents, has increased many folds. Burns was still manageable, but trauma has increased like anything. So the infection, prolonged hospitalization, limb loss, and economic burden. The economic burden remains the biggest problem with all of us. And doesn't matter how much insurance you have, it affects, if there is a chronic wound, it will affect you, anyone. These are the pathological textbook teachings, like what happens to a tissue injury. We have hemostasis, we have remodeling, we have inflammation, proliferation, and remodeling. Once the remodeling is complete, we get a scar. Now the newer things comparatively, some of them we have personal experience, some of them we don't have. Like the immunoregulations of healing in modern understandings. There are few key players. The M1 is pro-inflammatory and M2 is reparative, the macrophage ones. And there are some cells called T regulatory cells, which helps in healing of wounds. And of course, we know cytokines and chemokines. But these are all molecular level researches which are gradually peeping into our practical experience, but yet to come in a large scale. And obviously, persistent inflammation will lead to a chronic wound. Again, we are all listening to it for quite a long time, at least 20 years. The stem cell will change the whole scenario. Stem cell will stop all chronic wounds, and in fact, it can treat almost all diseases per se, starting from the hair loss to neural regenerations. But practically, these are the few which are showing some new ideas. All of them did not have done that well, but mesenchymal stem cells are doing well. Adipose-derived stem cells are still better, and for some particular conditions, we get bone marrow-derived cells. The mechanism is paracrine signaling, angiogenesis, that means starting of new vasculatures, immunomodulation, and extracellular matrix remodeling. Exosomes are coming. I do not have any practical idea about the exosomes, and there are some cell-free regenerative therapies are there. But they are all, majority of them are yet to get standardized. There are regulatory issues, and obviously they are very, very, very expensive. And most of them has come into the market. I find a lot of our pharmaceutical industry friends are also there. So and you are also familiar with the hydrogels, the collagen matrices, the alginate dressings, the dressings which has antimicrobial impingement on it, the smart dressings and the bioactive scaffolds. Smart dressings with their color change can detect change in pH, change in temperature, and there are some infection biomarkers. They have already come into the market, not in India, I presume, but they are in the market in Western world. But even in considering in the Western world, it's pretty expensive. There are bioactive scaffolds which supports cell migration, which supports angiogenesis, as I have said, and extracellular matrix formation. These, I think, most of you know, the Caltostat. I'm not supposed to take name, but just for understanding, it's easier for you to know which things work where. These are the alginate dressings and collagen dressings for burns. There's a next one on the right. And different type of collagens, collagen powders, and this is something called antimicrobial dressings as well. These are newer polymeric scaffold, the drugs or the nanomaterial which are impinged with the dressing material, and they gradually take over. They come to the molecular level and try to fill up the wound. There are nanomaterial loaded, there are drug doped, and natural extract loaded. These are also coming in the market gradually. These are gradually changing, and this is very helpful in diabetic foot ulcers particularly. Now there are some advances, I think, madam, they will talk about it later with the negative pressure wound therapy, commonly which we called VAC, vacuum assisted. They do macro and micro deformations, reduces the edema, the increased angiogenesis. Remember, everywhere this term is very important. The angiogenesis is always increased. And the NPWT have become portable. I think all of the hospitals are using it. And their single-use devices have also come. They're very good in particularly graft fixation, diabetic foot ulcer, also in chronic wounds. These are the newer kits. I think majority of you know about it. And there are some molecular therapies, the platelet-derived growth factors, the vascular endothelial growth factors, the epidermal growth factors, and TGF-beta. The gene therapies are emerging, RNA-based therapy. These are all still in laboratory level. We are thinking that gene therapy will change the whole scenario, yet to come. But controlled drug delivery system has come. But they have excellent, as I have said, excellent experimental results, but limited widespread clinical adoption. And this is the new thing really, because the AI has come everywhere, including the wound. They assess the AI-generated materials, they assess the wound, they assess the depth, they predict the healing, they do tissue classification, and the monitor can be done from faraway places. Smartphone-based machine learning algorithms are there, and digital wound database is also there. Early intervention can be done with the potential benefits, and remote care is definitely possible. But again, everybody, as Madam were stating that with digital photographs, we can do a lot of help. Digital photographs really helps in all these patients. But even in medico-legally, just because sending a photographs, although we all do it, may not be right all the time, because the photograph quality differs from phone to phone, the camera to camera, and particularly when a body part, whether it's viable or not, cannot be assessed on smartphone photographs alone. And of course, it will be the cost is high. The randomized control trial is comparatively less. Standardization is yet to come, and there are regulatory barriers. And personalized wound care is supposed to come. The 3D bioprinting is coming. It is coming for deep wounds. It's how much the depth, how deep is the wound, and the quality of the floor of the wound. This is coming through the 3D bioprinting. Skin substitutes are already there. I think Akhilesh will talk about it something. And cell-free regenerative therapy is also coming. So the wound healing is highly immune regulated. Regenerative therapies are rapidly evolving. Biomaterials and AI are transforming care, and translation into affordable clinical practice remains the major challenge. Because whichever company will bring it, they will obviously have their copyright, and they will charge pretty high. And then we shift to another point, acute versus chronic wound. This is also, I think, nursing personnel who are familiar with wounds, they know which one is acute and which one is chronic. Just definition. Acute wounds heal in predictable time frame. Chronic wounds fail to progress more than 4 to 6 weeks. Definitely we'll call it a chronic wound. This is again the same picture with hemostasis, the inflammatory phase, the proliferative phase, the remodeling phase, and cytokine response. These are obviously an acute wound. Anybody can tell it. Fresh trauma, donor site wounds, minimal slough or necrosis. These are all acute wounds. These are all chronic wounds which last beyond 4 to 6 weeks. Inflammation is present. And the biofilm formation and bacterial burden is also present. The slough, necrosis, the old ages, these are all pathognomic of the chronic wounds. I'm not going to all the treatment part. So how do you diagnose? History, assessment, the vascular evaluation, neurological assessment in diabetic wounds, microbiology and tissue biopsy when indicated. Imaging for osteomyelitis or a foreign body. And principles, I think we know about all this, hemostasis and irrigation, debridement, primary closure or delayed closure. Here you will need a medical person support. But the last line is very important. Tension-free closure and proper dressing is definitely very important. And chronic wounds, obviously the underlying etiology is the most important thing, and treatment of infection. And pressure offloading, particularly in diabetic foot. So the advanced wound care, as I have said, the negative pressure therapy, the skin substitutes, growth factors, hyperbaric oxygen, and PRP, the platelet-rich plasma, and regenerative strategies. So I'm not going to roll up plastic surgery here. So obviously it will be under a medical supervision. So the person should be knowing when a plastic surgeon has to be called. The infection, adhesions, hypertrophic scars, and contractures are all the complications. Recurrence, chronic wounds can recur, and nutritional optimization and patient education is also definitely very important. And here also there's a big role of nursing service. So early identification improves outcome. Acute and chronic wounds differ biologically. Management requires systemic evaluation, and plastic surgeon play a key role. Don't think that because we have a plastic surgeon, me and Akhilesh are a plastic surgeon, we're talking about plastic surgeons play a key role. There's definite any person who knows the wound, that any medical person who knows the wound well. Unfortunately, with today's curriculum and today's world, even for medical persons, very few know the wound well. That's why this line has come. And this is a very short slides for the wound care myths. Myth 1, wounds heal faster when left open in air. A lot of people will ask you this question, dressing na korle ki hobe thak, I hope more or less you understand Bengali, thak hawate শুকিয়ে যাবে. It never happens. Moist wound healing promotes epithelialization. Dry wounds from scab and delays migration or keratinocytes, and occlusive dressings improve healing and reduce pain. Number 2, all wounds need daily dressing changes. Not necessarily. Excessive dressing might harm you also. Day before yesterday, I got a patient who is dressing the wound 4 times a day, which is absolutely a no-no. Modern dressings, I'm not taking names, but 3-4 days, a lot of dressing material can stay at least 3-4 days. And dressing frequency depends on exudate, infection, and wound type. Pus means antibiotic. They are also a myth because the colonization and infection are not same. Antibiotics are indicated, antibiotics in the sense of systemic antibiotics are indicated only in clinical infection, and obviously overuse promotes antimicrobial resistance. And rather than putting antibiotics, antibiotic ointments and creams on a wound, it's very important to assess the wound properly, again preferably by a plastic surgeon, whether the debridement is required or not. If there are dead tissues, no amount, except few specific drugs, no amount of dressing will get rid of the infection and the dead tissue. And another, this is very common in peripheral areas, that hydrogen peroxide and iodine, they name it, hydrogen peroxide and betadine. Delay shop thik hoye jabe. It never happens. Cytotoxic, they are cytotoxics. And many times they impair healing in clean wounds. So it can be used. Obviously, they are good drugs. But you know when to use. You have to know that when you have to use, it has to be used judiciously in contaminated wounds only. More pain means the wound is infected. Pain may result from ischemia, edema, neuropathy, or dressing trauma. Infection assessment regards multiple signs like erythema, temperature, discharge, the smell, and systemic features. And chronic wounds are not just infected wounds. They are multifactorial: venous disease, pressure, diabetes, ischemia, malnutrition. Why I'm talking about the chronic wounds so much? Because it is really a menace all over, and a lot of people are suffering for this chronic wound. So the treating the underlying cause is very essential. And negative, the VAC therapy nowadays, since it is in vogue for last 4-5 years or more, so everybody is asking for VAC therapy, but it cannot, you should not use in many cases, particularly untreated necrosis, obviously in malignancy and exposed vessels. Exposed vessels, more amount of pressure, the vessels might open up and patient will bleed to death. Nutrition has a strong role, that we all know. Vitamin C, zinc, and protein. And this we all, still, I think everybody gets this question when we ask the patient to take bath. Then all hell fall loose. Snan korabo ki kore. So every wound, almost every wound can undergo normal cleaning procedure with normal water. Normal water means even the tap water. We, even in burn patients, 70%, 80% burns patients, we have bathtubs and where we clean them with normal running water, and you can use soap as well. So maintaining the local hygiene and cleaning the area with soap is utmost important. And it reduces the chance of bacterial colonization. This is all good theoretically, but 99% cases, not 99, at least majority of the patients fail to accept that. And as Madam was telling, there are some dressers who have minimum knowledge. They also tell the patient not to put water, as if the water is source of all infection and your skin and normal skin and other are not source of infection. So you need to clean the area with water and soap. There is no problem with that. So the time framework is the modern principle, the tissue management, the infection and or inflammation control, the moisture balance. It's better to keep the wound moist, and we have to check whether the age is advancing or not. And obviously every wound is a separate wound and needs to be individualized, and we need everybody's help. We means from medical team, different specialties, obviously nursing personnel. And again, I'll be happy to see if my nursing personnel gets done the dressing. I'm quite okay with that. And what Madam has said, I think these are, in a private setup, you don't allow your private dressers. Even if you have private dressers, in a good setup, you don't allow your private setters. I still trust the nursing personnel. But again, the quality differs. And again, in my hospital, in the private hospital, a lot of dressing are done by my nursing team, and it's absolutely, they are doing a great job. At times we need to take the patient to OT, then obviously we have to do our debridement and others. But again, as I have said, the government setup and the private setup are entirely different universe. So I think most of the people who have joined here are coming from a private setup. The moment these students get into the government setup, they turn into something else. They're all good. It's not criticizing anybody, but the idea, the concept, and everything changes very fast. Thank you. Thank you so much.
Thank you, sir, for your extensive presentations. We understand that wound management.
This is what.
We all understand that wound management is a challenge, but still it is inside the hospital. It is together with the doctors and nurses, wound management still remains much comprehensive, and it is manageable. But what happens in today's world, where Madam Avanti was also mentioning that when the patients are away from home, away from hospital, and they are going home with different kinds of complex surgeries, where we have after wound debridement, flap repair and all those are done, and with that patients are going home. How do you think the wound care at home we can bridge the gap as nurses, and what is like, because hospital counts SSI even patients when they go home. So how do we bridge that gap?
We can, provided, it's obviously better if a person gets dressed, if a patient gets dressed by a knowledgeable person. I'm not telling dressers are not good. At times, a lot of dressers are also good, but it's a problem for the nursing personnel, particularly who knows the wound care, who are with even private or government setup. They are not willing to go to the home or some other place where the patient stays. So there is a gap, there's a mismatch. People who are willing to do dressing at home. Smaller wounds, we can teach patients, relatives, they can manage themselves. But the larger wounds, particularly burn and other entities, there's still a big problem. We have some, particularly patients go outside, quite far away from a big city. There is a real gap because there's hardly anybody who knows how to do a proper dressing. So even if we do a skin grafting or a flap, I try to keep the patient, once discharged, at least 7 to 10 days, at least in a close vicinity of the hospital.
So do you think that nurse-led wound clinic in the hospital who can only concentrate on wound management in the hospital and outside the hospital can be a better option for all of us?
It can definitely be a good option, but it also depends on the mindset of the people in office or in the private setup. They have to find out, they have to think whether the sisters, they are willing to take sisters or brothers for only wound care management. So it doesn't depend on the doctors alone. Just we say we need a specific nursing staff for dressing only. it's, they will also always think about the profit and loss scenario.
Sir, the clinician's voice is much louder. So I think you can make a difference once you voice it out.
Of course it is, but we just take pride in our blue collar job. We are just a worker like anybody else. Because every day, the role of a doctor in today's India is getting clinician, not a doctor, I should say, less and less comparative to the corporate setup scenario and the mindset. So, if I don't do it, if Achilles doesn't do it, will be replaced. It has become, it's unfortunate but true. So everybody is dispensable. But still, we do, these are the negative points. I'm optimist with everything has changed in West Bengal also. So let's hope for the best. Hotei pare, hote pare na ta na. Kintu, there's another issue. I think we have a little bit of time, 1 or 2 minutes. There are huge, I look up the burn ward in SSKM hospital, which is supposed to be a big burn ward. Every day, lots, every day for 3-4 days. I think, I don't know exactly how many nursing colleges are there in West Bengal. I think it's around 78, 79, something like that. 119, so aro beshi. Jai hok. So almost everybody for burn training, I don't know what training they get, but they come to the burn ward of SSKM hospital for at least 3-4 days. It doesn't help anyone. It increases the infection load. And they write something. But whether this training helps anybody and this amount of nursing personnel, what is their future, that is also a big thing. Because obviously some will be good, same as medical colleges as well. 10 to 15% will be very good. Majority of them will be average and some of them will be very bad. So whether if we are getting so many nursing personnel from our state only, and a lot of people are coming from our other states. So what exactly they will do, say 5 years down the line, that remains a big question. To bridge that gap, we can think about if they know the this dressing and wound care therapies. If they know about it, it should help them, because if you can make it a mandatory, at least one person in each small setup also, then it will help everybody.
Can I?
Yes.
So one thing that can be done is, in fact, every nursing care, they are trained in the hospitals, be it private or government hospital, as Atiboda was saying. We also take part in training. Now, there is a referral system when a patient comes from periphery to the medical colleges, following the level of expertise, level 1, level 2, that kind of, from a PSC to a medical college. So it is up transfer, up referral. Similarly, when the patient is being discharged from, say, a medical college, he is going to his own native home, be it, say, Kalna or wherever, I mean, in the periphery. There is definitely a PSC, a peripheral health center. So if we can treat the nursing care of, and all the nursing care are getting trained in the colleges, in the nursing college. So if they are trained, we can jolly well with confidence refer the patient back to his native place and ask him to visit the peripheral health center where a nursing care is manning the health center, and a clear instruction when it is given, it's followed. So the problem is solved. It's very easy to solve. It's just that you have to take some effort to implement this. Regarding others, we definitely train our nurse dressers, so-called dressers, though they are paramedics. They are not qualified, if you talk about it, getting a degree or something, but they do a wonderful job because they are trained, they are seeing us working, they are seeing us dressing the wounds, so they catch it up. So if they can catch up how to dress a wound, anyone can catch up. So it's just that when we have a referral system coming from a peripheral health center to a Apex center, we should have a down referral system wherein a patient from a Apex Institute goes back to peripheral health center manned by a nursing staff for the dressings. So that should take care of the wound.
Thank you, Dr. Akhilesh, for bringing
Madam,
it.
just one thing. So the dressing is a very gray area. Who is the dresser or who will dress the wound, as Akhilesh was telling, once a patient goes back from Calcutta to some other peripheral. So a lot of people, we do not know. So for that, I think rather we should have a standardization like we have in Western countries, at least an examination or licensing examination that this girl or this boy can do dressing. There is no proper dressing code anywhere in India. Just if you see, as Akhilesh was telling, few people who see us doing dressing, gradually they do good job. But again, there is no regulation. So if a regulatory body or a licensing, any type of licensing, small examination, I think that will help both the patients and the system as well. Thank you.
I think it is bringing a good discussion about now leaders, nursing leaders, to think of top of licensures program for nurses. And that is another channel getting opened, and we have to think now to channelize our nurses for the specialization to this extent what we are discussing today. Thank you, Dr. Tipper, for your...
Ma'am, if I can include something, that regarding home care you were saying, and as Sir was also saying, NABH 6 standards does demand to have domiciliary care in AAC chapter. So it is up to the organization that we should prepare wound care nurses, because domiciliary care does include wound care too. So if suppose organizations are not helping us, not supporting us, so NCs will support us.
No, but that is going to affect the organization.
Yes.
If we are not able
Yes.
to take care of wound, ultimately it counts in the hospital only.
Understood.
Surgical site
But
infection
as per
rates.
standard, we are supposed to implement that too. Thank you, ma'am.
Thank you, Doctor.
Thank you.
Thank you so much. So I think we finished wound management first, but we were supposed to be doing wound assessment, which comes with for Dr. Akhilesh Kumar Agarwal, who is the consultant department of plastic surgery, Manipal hospitals. He is going to talk about bridging the gaps in wound assessment. What should we see and document?
Hello everyone, I am Dr. Akhilesh. I'm a plastic surgeon by training. So when it comes to bridging the gap of wound assessment, there are multiple aspects in that. One is a clinical aspect and one is a medical legal aspect. So I'll be speaking briefly on why. So first of all, nursing care forms a backbone of any medical facility, because they are spending most of the time, the patient rather spends most of the time under their care. The clinicians come, give rounds, go away. Patients are in contact with the clinicians, especially the surgeons during the operation theater, and then it's the rounds. So they know more about the patient than the doctors, and in fact, they are the bridges who inform the clinician about the day-to-day development of the patient, whether the patient is improving or deteriorating, and that includes the wound as well. So documentation is helpful, as I was speaking, medico-legally, about prognosticating of the wound, about when we are handing over the patient, and the progression of the wound. I'll be briefly speaking on each of the topic. Medico-legal comes when a patient is getting admitted. All the wounds of the patient should be documented. It has got a medico-legal implication because later on it can be charged that the wound happened in the hospital. The patient was not brought with the wound, and this frequently happens when a patient is in the hospital for a long time, especially when he develops a pressure sore, which is a menace. A patient is going for a surgery, he may, under the operation theater, he may develop a diathermy burn. If it is not registered, it's a problem. A chemical burn because of betadine, Savlon, or spirit, etc., that's a problem. So what do we document? One, we document when a patient is received, be it intra-hospital, from one ward to other, from one department to other, be it inter-hospital, when a patient is received from another hospital. That needs to be documented. Is he having any wound anywhere in the body? What kind of wound it is? What size of wound it is? What is the condition of the wound? And if at all the patient is having a pressure sore, what is the stage of the pressure sore? Patient should, going for the surgical intervention, should have a documentation, especially when a patient is scheduled for a surgery which is lasting long and requires special position, like a patient is being put up on a stirrup for, say, urological surgery or a gynecological surgery, pressure points, the bony prominences should be checked and documented for the presence or absence of any pressure sore. Documentation should be made on how the patient is going to be positioned in the surgery. As in the pre-op, it is mentioned what surgery it is being the patient is scheduled for. We have a brief idea of which position, whether the patient is going to be lying supine, prone, or on a stirrup. So especially those bony prominences should be noted for presence or absence of any ulcer, and this applies both when seeing of the patient to OR and receiving the patient from OR if the ulcer has developed during the course of surgery. Diathermy burns I have spoken about. Chemical burns because of savlons, betadines, any of those spirits, etc. Or in an orthopedic surgery where bone cement are being used and there is a spillage. There may be an ulcer which was not there early, and if it is not documented, the brand falls that this happened in the ward itself. There are special patients, bedridden patients, we have to see for pressure sore. For that, I have put this picture, most common areas of pressure sore, and while receiving the patient should be log rolled. Every patient, when he comes, especially in the trauma, should be expected to have a cervical injury. So cervical fixation, immobilization, and log rolling has to be done, because most of the areas where a pressure sore develops, it's in the hidden area. It's not in the exposed area, it's on the back. So log rolling, it hardly takes any time. Document any presence or absence, and a good way is, if there is any ulcer, take a video, photograph and tag it, either in the EMR or take a printout and fix it in the BHTs. Patient on ventilation. Patient may be having intertrigo or maybe having excoriations when the patient is received. That needs to be documented. Patient who is on ventilator, the pressure area, especially on the nose when the patient is on BiPAP, or nostrils when the patient is intubated, these needs to be checked. Phlebitis, a patient is having IV access. Most of the patients in the wards or in the critical care units, they are having peripheral access. So phlebitis should be looked for and documented. Any patient, as I said previously, of intra-departmental, when a patient goes from the ward to a critical care, should be documented. If there is any early stage of pressure sore or any ulcer, it needs to be offloaded. If there is any change in discharge, a transurative wound, which we can easily assess by seeing the last layer of the dressing, whether it is yellow or white, or it is green color or bloody, any change from the previous dressing should be documented. It gives an idea to the clinician whether there is any new infection that has set in. What kind of infection? Because we all know green means Pseudomonas. For example, I just arbitrarily mentioned it. So if this is mentioned, it gives an idea to the clinician that, okay, there is a new infection, a new bug which has crawled in, and we need to send for a culture and change the antibiotic accordingly. Special dressings, especially NPWT, as Dr. Banerjee had mentioned, they need to be monitored. The character of the exudate or transudate which is getting collected in the container, whether it is becoming pus-like, curdy, muddy, or suddenly you see it has changed to bloody. Bloody means there has been an erosion in the bed and patient is exsanguinating. We need to raise an alarm, call the clinicians to have a look if there is any bleeding, and that needs to be arrested. Inter-hospital, when a patient is being taken in the hospital or being discharged to another hospital, all the wounds have to be assessed and documented. This is necessary because later on it can be charged that we received the patient with this wound from the previous hospital. It may have happened in the next hospital or at home when the patient is going for a domiciliary care. So if it is mentioned, we are saved from a lot of headache. This is the diatomy burn, chemical burn, which happened in the patient after we received from the OR. Proper documentation helps in prognosticating. The first picture, it is a pressure sore. It is going towards second degree. So if the patient is offloaded, offloading dressing is done, change of posture is done, patient is put on air mattress, and the clinician is informed, we can save the patient from any surgeries and other dressing problems. Just these simple nursing changes will help us cure this disease. As I said, nip it in the bud. But if it is not mentioned, we can see what happens. The next picture, it has gone to a third degree or a fourth degree pressure sore, which means the patient requires antibiotics, requires dressings, surgeries, and later on a reconstruction. Change of character of the adjoining skin. A wound having a normal scale in the periphery, if it suddenly becomes reddish, that means some new infection has happened. Patient is developing cellulitis. If not taken care of properly, patient can develop a life-threatening necrotizing fasciitis. Change in color of overlying skin. As you can see here, from a reddish hue, it went to eschar formation. So that needs to be mentioned. Change in discharge. A transudate which is white or transparent or a straw color, if it changes to muddy, that means it's becoming exudate. That means some infection is set in. Or if it is an open wound, some fat necrosis is happening. That needs to be documented and informed. If the dressing suddenly changes bloody, especially the container of an NPWT, if it changes bloody, it needs to raise an alarm that maybe there is an erosion of a blood vessel, patient is bleeding, and that needs to be addressed. So I have already discussed about how it helps in the treatment of a patient. Proper documentation, abreast the clinician about the changes, change in the strategy for treatment, and also saves us from a lot of headache. When this, I have mentioned the volume of discharge, the character of the discharge, as well as the smell of discharge. These help us identify a new infection. Drains in an abdominal surgery are frequently given. If there is a sudden change in the collection of the drain, if it changes green or fecal material is coming, that needs to be informed to the clinician that maybe there is a gut erosion, maybe there is a gut injury peroperative, or later on the drain has eroded into the gut and has led to some complication that needs to be addressed. For NPWTs, because this is a new modality and is in vogue right now, all the chronic wound patients are having NPWT. Documentation has to be made about the percentage of leakage, sudden change, volume of collection, and type of collection. So to conclude, documentation of any change in the condition of patient is vital for optimal treatment. Regarding wound, proper documentation helps in avoiding medical legal outfalls, strategize change in treatment, makes difference in the final outcome. Regarding the wound care, we have to look for the presence or absence of any wound, whether receiving the patient or discharging the patient. Thank you.
Hello. Thank you, Dr. Agarwal. It was a wonderful presentation and we finished it on time. You finished on time. Congratulations. So, sir, on behalf of, as a clinician, what are the expectations from a bedside nurse in terms of wound assessment?
So mostly if the wound is already dressed, so when the wound is changed and it is happening in absence of the clinician, we need to see the documentation that is expected is the edges, the kind of discharge, especially on the last layer of the dressing, not on the superficial layer. Because superficial layer, whatever comes, it is seeping by siphon action. So it is not giving it's not going to give us any right idea of what kind of changes are happening deep inside. Change in color. Then if there is any change in skin adjoining or overlying the wound, that needs to be mentioned. So that's about it.
Sir, I feel that the dressing can be done only after the inspection of the clinician, because if any culture swab has to be taken or anything.
Yes, that's right, ma'am.
Yeah.
But there are conditions where, like, there is a standing order that dressings to be changed every third or fourth day. And for some reason, if the clinician is not present at the time of the dressing change, these points need to be noted. Then second, what helps any clinician is when the patient is being sponged, patient is turned, log rolled. So the condition of the back, a patient who's bedridden for a long time, or who's on a ventilator for a long time, or any CVA neurological patient who cannot change his position. So the condition of the back, the genital area, the perianal area, these need to be documented and informed. And especially if a patient is obese and he's having a huge panniculus, intertrigo, as I had mentioned in the slides, a patient developing infection in the skin folds, which commonly happens because of the sweat getting accumulated in there. That needs to be informed, because that may harbor fungal infection, especially in an immunocompromised patient. As we know, diabetes is rampant nowadays. So an immunocompromised patient having an intertrigo should be mentioned. We need to change it to look for any fungal infection and instill any fungal treatment if required.
Thank you. So nursing assessment does play a crucial role.
Definitely.
Thank you. Over to ma'am.
Thank you, sir. So anything if you want to add?
That's it. Thank you very much.
Thank you so much.
Thank you. Please, I'll sit.
No, I'll take it up.
I'll sit down.
Now,
Ma'am, you have a seat, I'll sit there.
Sit.
It's blocking the
Yeah,
screen.
it's not the same.
There is a chair.
So I would request now Ms. Poulomi Roy Chaudhuri, Senior GM Nursing, Charnock Hospital, to talk about risk assessment and early detection to prevent worsening and complications of wounds. Poulomi, please.
Somebody, where is the slides? Oh, this one. A very good morning, everyone present over here. First of all, from the bottom of my heart, I'd like to thanks to the BCCI for inviting me as one of the speakers. Thanks to my organization, Charnock Hospitals, and our hospital director, Madam Shweta Sharma, for allowing me to present in front of this auspicious gathering. And thanks to the chair and the co-chair for these wonderful introductions, and definitely to both the doctors for this wonderful presentation. So my topic is risk assessment and early detection to prevent worsening and complication of wounds. I will talk something very basics, but that are very important to understand this concept. So what is wound? A wound is defined as a break or disruption in the normal continuity of the skin, mucous membrane, or underlying body tissues caused by physical, chemical, thermal, or mechanical injury. So the expected outcome by these sessions, definitely every member should be able to identify at-risk patient, initiate early preventive measures, and escalate concerns properly. So I know that my speakers, they already mentioned something, but why the early detection matters. So if the early detection doesn't happen, what are the consequences that we should know first? First is the increased risk of infection and sepsis, delayed healing and tissue damage, higher chances of amputation in severe cases, increased length of stay, increased healthcare cost and burden. And what are the benefits? Just opposite. Reduction in the hospital-acquired infections, lower mortality and complication rates. So I can give you one example. If suppose one diabetic foot ulcer identified in day 2, that can be managed successfully with proper dressing and monitoring. Whereas on the day 10, if we just identify that one, prolonged antibiotics and ultimately even the limb-threatening intervention also can happen. So again, the detections and early detection matters. So the common risk factors, I know that my previous doctor already mentioned, but if we classified the common risk factors in different aspects like patient-related, wound-related, and system-related. So under patient-related, we have the diabetes, aged above 65 years, malnutrition, immobility, peripheral vascular disease, smoking, or poor circulation. Wound-related, definitely there are large or deep wounds, pressure of necrotic tissue, heavy exudate or moisture, contaminated or infected wounds. And system-related, again delayed wound assessment, inadequate monitoring, poor or incomplete documentation. So the classification of wound, so I just would highlight the basic classification of wounds based on the reference from CDC, WOCN, and NPIAP. So with the picture, so that we can again just, I know that we all know these things, just to recapitulate these things. So based on the duration of healing, there are acute wounds and chronic wounds. So acute wounds is wounds that heal within expected time frame like any surgical wound. Then we have the chronic wounds, that is the wounds that fail to heal in an expected period, so that is pressure ulcers. Based on cause of injury, we have intentional wounds, again that is the surgical wounds, and unintentional wounds, we have abrasions, lacerations, burns, and pressure injuries. Based on the skin integrity, again there are open wounds and closed wounds. In the open wounds, when there is a break of the skin in mucous membrane with the exposed tissue, we have examples like laceration, ulcer. In the closed wounds, this is very important, that skin remains intact, but underlying tissue is getting damaged, like there is hematoma, contusions, and other things. So based on level of contamination, this is clean wound, clean contaminated wound, and infected and dirty wound. I think with the pictures you can see over there. Another important aspect is the based on depth of tissue damage. So based on the depth of tissue damage, we have the superficial wound, only involvement of the epidermis, partial thickness wound, that is the involvement of the epidermis and dermis, and full thickness wound, that is extends into the subcutaneous tissue, muscle, even bone. So stages of the wound healing, I know that again that my previous speaker mentioned this one, but I would like to highlight these things with specific points. So first is the hemostasis phases, immediately after injury, minutes to hours. Purpose is stops bleeding and protects the wound. What happens actually? Blood vessels, the constriction happened, platelets aggregate, and the clinical signs are the bleeding stops and clot formation. Here comes what is the nursing focus. Control bleeding, maintain sterile dressing, and protect the newly formed clot. The second is the inflammatory phases, that is 0 to 4 days. Here the purpose is to cleanse the wound and prevents the infection. Again, what happens here? Here the vasodilation occurs, white blood cells migrate to wound. Clinical signs are the redness, warmth, swelling, mild pain, and exudate may be present. And key nursing focus, again, monitor for infection, assess pain and inflammation. Third is the proliferation phase, that is normally 4 to 21 days. Purpose is fills and closes the wound. What happens actually? The granulation tissue forms, collagen synthesis increases, and clinical signs, mostly the pink or red granulation tissue, reduced wound size, and new skin formation. Again, here the nursing focus is maintain the moist wound environment, as the previous speaker already mentioned this thing very categorically. So support nutrition and hydration, protect fragile granulation tissue. And the fourth phase is the remodeling and the maturation phase. Normally that happens from 21 days to 2 years, so strengthens and reorganizes the tissue. Collagen fibers reorganize, and clinical sizes, scar becomes flatter and paler, and tissue becomes stronger over time. Key nursing focus, prevent scar breakdown, educate the patient on skin protection, monitor chronic wounds very carefully. So this is the stages. So already we talked about this one with the pictorial diagram. Now this is very important. I will not discuss in details of this one, but few important points are very important. What is the cycle of wound assessment? To understand the risk and other things, this is very important. First is the wound assessment. Second phase is the schedule the wound reassessment, when we are supposed to do the reassessment. Third is the dressing selection and treatment regimen. Very important. Peri-wound preparations, that means the wound bed preparations, pain management, another important aspect during doing this sort of wound care. Treat the concomitant conditions, like if there is any infection, edema, malnutrition, or poor circulation is there or not. Treat the underlying conditions, whether the patient is having diabetes, whether vascular disease or immobility. thorough documentation, evaluate healing. If there is some sort of problems, modify the treatment and discontinue treatment if suppose the wound totally closure and wound things is done. So role of the nurse. So every aspect, there is a very crucial role of the nursing is there. So first is the key roles of the nurses in wound assessment is the assess wound and surrounding skin, identify the infection and the delayed healing, evaluate the risk factors, monitor and document the wound progress, implement the appropriate wound care, educate patients. One of the important aspect is there, and the educations, I just would like to highlight that NABH 6th edition, Madam is also there as a principal assessor. So NABH 6th edition focuses more on the patient and family educations. Not only the educations, we are supposed to get the signatures showing that what is the conditions of the wound. Importance of nursing assessment here, the promotes faster healing, prevents infection and complications, improves patient outcomes, and supports the timely treatment and decision. So ultimately, early assessment and timely intervention, that gives us the better wound healing and fewer complications. So this is one of the important things, that is the different risk assessment tool. So mostly for the risk assessment tool, you are using the Braden scale, Norton or water flow, but most of the hospitals we are using the Braden scale. So the benchmark is the developed by Barbara Braden and Nancy Bedstone and widely recommended by the National Pressure Injury Advisory Panel and International Wound Care Guidelines. And we were discussing that after the wound is happened, so what sort of measurements tool that we will do. So we have the push tool as well as we have the Betz-Jensen wound assessment school, that tool is there, but mostly again we are using here the push tool, most of the hospital. So this is, I think all of us, we know about the Braden scale. So we are doing the sensory perception, moisture, activity, mobility, nutrition, friction, and shear. And interpretation score is if there is less than 18, so that is at risk. And for the push tool, that is a wound healing monitoring tool used after a wound develops, helping prevent worsening and complications through regular assessment, which is very, very vital. So purpose we all know, use also we know, developer benchmark already I mentioned. Parameters is the wound surface area, exudate amount, and tissue type, and if there is a higher score, definitely worse wound, and the lower score is the healing stage. So risk assessment tool, I think somebody also mentioned about the time framework. This is also very important. Tissue management, infection and inflammation control, moisture balance, and age of the wound advancement. So early warning signs, as a nursing personnel, what are the early warning signs or the red flags? Look for increased pain, whether there is a redness more than 2 centimeters, whether there is a pus or foul odor, and exudate is present, and delayed healing. And what are the systemic signs? If there is an increased WBC and CRP, fever and chills. So alertness is if it is red, hot, and smells bad, escalate immediately, don't delay. So preventive strategies, first is the assessment, and I already mentioned what are the different assessment criteria, risk assessment tools. Second is very important is the offload pressure. Reposition patient every second hourly, use air mattress, heel protections, avoid prolonged pressure on the bony prominences. Nutrition support is another important aspect. Definitely the infection control, that is a maintain aseptic dressing technique, strict hand hygiene practices, very, very important aspect. Early identification of infection signs and education already I mentioned. So this is very important of the preventive strategies. So in our hospital also, in Charnock Hospital, we are using this risk assessment tool, that is the Braden scale assessment. We are using the 2-hourly position changing in the Braden scale assessment, and that position changing actually happening or not, that senior nurses, the in-charge nurses, they are evaluating this thing and they are putting the signature. And push tool also we have implemented. So this QIP's quality improvement project, I know that most of the hospitals, we have taken this project, HAPI, and in our organization also we have taken this HAPI project, because this is one of the challenging aspect and one of the very important aspect to take care as a nurse. So happy we have taken this project in the last year, and we could drastically reduce by developing, after brainstorming these PDCA cycles, few things we have implemented, like develop happy questionnaire, audit staffs for the checking current practices, process flow mapping, cause and effect analysis, and all these things we have done, and we have drastically reduced the happy numbers. And what are the sustenance plan? We are just taking care of this sustenance plan also. First First is the identification of happy causes and risk factors, early identification of high-risk patients, nursing intervention as per risk assessment, continuous supervision about secondary position changing and back care, intensive staff training on proper Braden scale assessment, on-job unit-based training on pressure injury prevention strategies, provide pressure relieving devices, very important, focus on patient and family educations. So in conclusion, I just would like to mention only 4 A's. First is the assess early, identify risk before damage occurs. Second is the alert early, recognize the warning signs promptly. Third is act early, intervene without delay. And fourth A stands for achieve better outcomes. So faster healing, fewer complications. So every wound tells a story. Early assessment can change the ending. Thank you.
Thank you, Poulomi. I think that was an extensive presentation from the nursing point of view. How many ICNs are present here? Can you raise your hands? Do we have ICNs? So I would like Poulomi to emphasize on what are the wound surveillance as an ICN, the ICN's responsibility, just 5 aspects if you can mention.
Yeah, this is very important. I think infection control nurses, they play a very pivotal role in the hospital settings, and you know that the presence of infection control nursing also, as per the number of the beds, also has become mandatory as per the NABH guidelines. Suppose 100 beds hospital, how many ICN? 200 beds. So that depends that the ICN's importance is there. Definitely, ma'am, what you mentioned is important point. Whenever the ICN is going, so they have to check that few parameters, that if suppose there is a wounds or pressure ulcer are there, whether the push tool happened properly or not. So suddenly they can just check with the measurement scale that the actual measurement is happening or not, whether any sort of depth is there or not, and they have to check periodically, like suppose today few samples, tomorrow few samples, and they have to cross-check whether it is done properly or not. So this vigilance, this surveillance is mandatory from the infection control nurse perspective.
Thank you so much. And I would mention one thing, that many a times we send cultures and we don't chase for the reports.
Yes.
We forget about it.
Yes.
But I think our responsibility goes to that extent that we chase for the report and see that what is the report and intimate and take appropriate action accordingly. Thank you, Poulomi.
Thank you so much. Thank you, ma'am.
Coming to our last speaker, Ms. Jessie Saji Varghese, who is the head of nursing, HCG Cancer Hospital, Kolkata. Jessie is going to speak today on burn injuries in hospital settings, its consequence, prevention, and measurement.
Good afternoon, everyone. So coming to our panel, the last presentation, I am Jessie. I am from HCG Cancer Center, Kolkata. Burn injuries in the hospital settings, which are not at all acceptable, or we do not expect it to happen, right? But sometimes it does happen. So we will go through the things that how we can prevent, how we can early assess, and how we can be safe. Hospital-acquired burn injuries are relatively uncommon, but are considered preventable patient-safe incidents. Studies from the developed healthcare system suggest that hospital-acquired burn account for less than 1% of all reported adverse events. But still, notable incidents and triggers in the hospitals in Kolkata. This is only in Kolkata. In the month of April, we had a blaze triggered by short circuit in an air-conditioned unit of a cath lab promoted a massive emergency response and the evacuation of roughly 70 patients. In October 24, a major ground floor fire necessitated the shifting of 80 patients. One patient trapped in the ICU died because of smoke inhalation. In July 2021, an 11 days old infant suffered burn injuries due to a technical glitch and a temperature spike in an ICU. December 11th remains one of the most devastating hospital disaster in Kolkata history. The fire reportedly originated in the basement where the flammable materials were illegally stored. More than 90 people's lives, including 2 of our colleagues, were lost. Now we will look into the types of burn that can happen in the hospitals. Scald burns, that means it's coming from a steam, hot water, or a hot substances. It can be also from a hot food which is served. Flames burns, electrical burns, chemical burns, inhalation burns, radiation burns. Identify the cause of the burn. Ask. What are we supposed to ask? What caused the injury? Flame, hot, liquid, chemical, electricity, radiation. When did it occur? How long was the exposure? Was any first aid given? Assess the appearance of the burn. What are we supposed to assess? Burn depth, appearance, pain level. In first degree, redness, dry skin, no blisters, painful. But in second degree, partial thickness, red or pink, moist, blisters present, very painful. Third degree, full thickness, white, brown, black or leathery skin and little or no pain at the center. In fourth degree again, chattered tissue, exposed muscle or bone, usually painless at the deepest area. Assess the size of the burn. Estimate the total body surface area affected using rule of 9, land and border chart for children, and patient's palm method. Not the healthcare worker's palm, it should be the patient's palm which is used because it comes as the palm is 1% of the total body surface area. Assess circulation and neurological status, check skin color and temperature, peripheral pulse, capillary refill, sensation and movement of affected limbs. Check for signs of inhalation injury, look for burns on the face, neck or inside the mouth, sinonasal hair, soot and around the nose or mouth, hoarseness, difficulty of breathing, again, breathing or stridor. Quick nursing assessment rule. Look, feel, ask, measure, escalate. Look at the burn appearance. Feel for the temperature, pulses and sensation. Ask about the cause and symptoms. Measure the burn size. Escalate severe burns immediately to the physician or burn team. Now we come to the consequences of burn injuries. For patient, pain and tissue damage, extended hospital stay and higher treatment costs, psychological distress, reduced quality of life. Now coming to the health worker if it happens, physical harm and potential long-term health consequences, increased absenteeism from work, emotional stress, anxiety and psychological impact, lower staff morale and job satisfaction. Impact of burn injuries on healthcare organization. Increased healthcare cost, extended patient length of stay, potential legal or regulatory consequences, damage to organizational reputation, increased workload for healthcare teams, staff shortages and productivity loss, need for corrective actions, investigations, and quality improvement initiatives, impact on patient safety indicators and accreditation standards. Burn prevention framework for hospital, and this is for the nursing practice. Burn safe model. B stands for be vigilant, U for use of equipment safely, R for reduce environmental hazards, N for nurse education and competency, S for screen and assess continuously, A for act immediately, F stands for foster and culture of safety, E for evaluate outcomes. Measurement and monitoring for burn injuries in hospital settings, incident reporting and documentation of burn events, root cause analysis for every burn related incidents, monitor burn injury rates and trends, conduct safety audits and compliance checks, track staff training completion and competency assessment, develop quality indicators for patient safety. Key takeaway: prevent burns, ensure safety, protect patients, save lives. I sincerely thank the hospital management, quality team, healthcare professionals, and all colleagues of their guidance, support, and commitment to the patient and staff safety. My special thanks to Rubali Ma'am, Regional Business Head, East and AP HCG, Guruvinder Sir, Chief Operating Officer, HCG Kolkata, Ms. Punita Rani Singh, VP Nursing Administration, HCG. Thank you for your attention. Patient safety is everyone's responsibility. It is not only a single person, patient safety officer or a quality person. No, it's a responsibility of every person in the hospital. Thank you so much.
Thank you, madam. Very truly said. Patient safety is everyone's responsibility. To go with the questions, I would like to ask, is there any difference in prevalence of burn-related injuries between private and public sectors? And if so, then why?
Of course, ma'am. When you look into the prevention methods in the private sectors or in the coming to the government sectors, when we look into, we in the private sectors, we take it more seriously when it goes, or because it's a, there is a, as I told already, there's a reputation which is affected, the hospital reputation, not only that, the patient safety is also very much taken care in the private sectors. Not only that, it is not, I'm not mentioning that it is not taken care in the government sectors, but more is being given, the emphasis is more on to the private sectors we look into. And not only that, when an incident happens, it's more affecting the private sectors than the government sectors, I think. That's my opinion.
Okay. So maybe is it related to private sectors are opting for the standardization of practices?
Of course, of course.
Programs?
Yes, of course, yes. We look, see, even if you look into the hospital practices, like we very often look for the code reds, mock drills, tabletops, and we look into each and every point where the fire can be prevented, what can be done, and the equipments checking, because it's more important of checking the equipments, whether they are in working conditions. Suppose if a fire at all, if at all it's not expected to happen, if at all it happens, the equipments, if it is not in a working condition, suppose if the paging system or your announcement system is not working, the things can go worse and beyond the control.
I think Shampa is not agreeing to the statement that you have given.
Madam, I differ from you. The reason behind this, we are very much concerned in the private sector regarding the any injury or any incident, it is reported and documented. So we can get a status. What is the your incident? Because we based on the benchmark and indicators. Whereas the burn happens in the government sector also, and it has.
But it gets not notified.
Taken care also, but it is underreported. So we can compare. Like it is more in private sector or less in government sector or reverse. That actually I want to say.
Thank you, ma'am.
Any research data is there or statistics is there that public has more burn than private? How do we conclude?
Ma'am, that kind of data, I don't think we, usually the government or anybody will publish it. I don't think so, because it's...
Yeah, because because we cannot conclude that yes, public has more burn. We cannot disrespect the nurses working over there. And if it is for reporting, the patients themselves will report in public sector.
No, Mohua, our
Ma'am,
concern was not in the terms of number of incidences. Our concern was what is the difference in practice. That's what we wanted to highlight.
Yes.
So if I should, I think this discussion should trigger that yes, how can we think of now
Yes. In
making a
both
data
sectors.
repository or something, look at that where we should stand, how standardized practice can make a difference.
Yes, in both sectors.
In both sectors. Yes.
It's not that it's not reported in it happens in government sector as well, and it is reported. At least I'm not talking about the extreme peripheral hospitals, but at least in medical colleges in Calcutta, they are reported. They are reported. I think the nursing personnel and the higher ups, they also take their appropriate steps. And whether it has been published as a paper or not, that I cannot tell you, but reports are being taken, and it is taken care in appropriate level and the treatment wise everybody. Because what Madam has said, something goes wrong in a government setup, you'll come to know by media channel within 10 minutes. So it's not that you can hide anything. So it's there. Maybe the numbers we can make out. Actually, if you want, we can try to get how many numbers in one hospital. I think we can make out. If you try, you can get the numbers as well. But they are also taken care of. It's not that they are not taken care of. They are also.
Very rightly said. Thank you, and with that,
Thank you, ma'am.
Come to the end of the panel discussion. Thank you, Saji. I hope that this has created a thought process in us, provoking thoughts, that yes, now we take the wound care to a focus and ensure that we have a standardized practice across all settings.
I think we were discussing since morning time that as a bedside nurses, because I think these 2 points I thought of highlighting, sorry, I just would like to tell that one. As a bedside nurses, they are feeling some sort of, that they are scared to whether they will opine related to any sort of care decisions related to the wound or not. So that is a big question. So they are a little bit scared. So I think as a nursing leaders, because most of the leaders are present over here, we have to take this ownership to building a culture of empowerment where every nurses feel confident that their voice also matters. So that is one of the most important, and as a leaders, we have to take this. So 2 things we have to take into consideration as a leader. It is our responsibility to improve the knowledge and skill of the nurses in that particular field. And secondly, we have to build a culture of empowerment where every nurse's voice matters. Thank you so much.
Thank you, Paulami, for highlighting this very important point. And that is the take-home message from this panel discussion and plenary session. So thank you all so much for being participative to the speakers and as well as of the dais. Thank you so much.
Thank you, ma'am. Now we have a pleasant task to perform. Sir, I would request to please be in the middle of the dais. Sir, please. I request the chairperson, ma'am, and the co-chairperson to please present the mementos on behalf of Bengal Chamber to the speakers. To Dr. Akhilesh Kumar Agarwal. To Dr. Tibar Banerjee. To Ms. Paulami Roy Choudhury. And to Ms. Jessie Saji Varghese. I now request Avanti ma'am once again to please be on the dais to do an honor of presenting mementos to the chair and the co-chair on behalf of the Bengal Chamber. To our chairperson, Captain Madhukari Ray. And to the co-chairperson, Ms. Manushi Bhaskar. I request the dignitaries for a group photograph, please, also. For a group photograph, please. Thank you. We will take a short break for changeover to the next sensitizing session, and Oendrila will take over.
We now proceed to the sensitization session chaired by Madam Dolly Bishwas, Chief of Nursing, Fortis Hospital, Anandapur. Let's welcome ma'am with a huge round of applause, please.
Our first presentation is on diabetic foot ulcer prevention and care, a dynamic approach by Ms. Sujata Angela Singh, Chief of Nursing, ILS Hospital, Dum Dum.
Sujata ma'am, please come to the dais. So we have Madam Sharmishta Roy, Senior Ward in Charge and ET Nurse from Tata Medical Hospital, to present her topic on negative pressure wound therapy, pros and cons.
Today, as a speaker, we have with us Professor Dr. Mahua Kormakar, Nursing Superintendent cum Officer, Jagannath Group Institute of Medical Science and Hospital, to deliver her expert knowledge on heel ulcer prevention and management.
Now I am handing over the baton to Dolly ma'am.
Thank you very much. I hope the participant delegates, all of you are enjoying the session. Very enriching scientific session. The first plenary, which is chaired by Captain Madhukari and co-chaired by Manushi, has done, and our eminent speaker who have enlightened us with lot of knowledge. And I am sure the participants, those who are sitting over here, must think that you all are the wound manager, isn't it? And today, whatever gap or whatever the lacunas you had in your mind, please try to clarify today, ask questions and get the understanding in detail. So we will go ahead with the sensitizing session. It is sensitizing session because there are the topic which we have chosen for this session. Diabetic foot ulcer is very important. Negative pressure wound therapy specialist Sharmishta is sitting over here to enlighten us, and the heel ulcer, which because of the nursing negligence sometimes patient come across. So first I would like to welcome Sujata. Sujata is having vast year of experience. She has done her BSc nursing and followed by her masters, and I think she has completed her MBA as well. PhD, yeah, you are Dr. Sujata. So Dr. Sujata Angela Singh is with us to give a lecture on diabetic foot ulcer prevention. So Sujata, most welcome, and for taking up this session today. So kindly start your talk here.
Good afternoon, everybody. I want to thank my respective seniors, the BCCI, and all my colleagues sitting here. I have prepared the slide in a very, very basic manner. You already know all about it. We will just do the refreshing of it so that we can go back again. While we practicing, we can apply it again. So my topic today is diabetic foot ulcer, prevention and care, a dynamic approach. Understanding diabetic foot ulcer, what it is all about, very briefly I'll tell you. A diabetic foot ulcer is an open sore or a wound, typically on the sole of the foot, that develops in individual with diabetes. Prolonged hypoglycemic damages the nerve and blood vessels, reducing sensation and blood flow. Minor injuries go unnoticed and heal very slowly. So creating a pathway for infection and ulceration. So if you see, 15 to 25% of the people with diabetic will develop a foot ulcer in their lifetime. Now, Wegener, grade 0 to 4 I have written, but basically it is 0 to 5. I'll show you a next slide later. Classification ranging from high risk foot to a localized gangrene or a full gangrene foot. Then leading cause, if we look at it, the diabetic foot ulcers are a primary drivers of lower limb amputation worldwide. So the global burden of diabetic foot ulcer. Diabetic foot ulcer represents a major public health challenge. Prevalence is high in low and middle income countries, driven by limited healthcare access, delays diagnosis and inadequate patient education. So diabetic foot ulcer accounts for a substantial proportion of the diabetic related hospital admission and non-traumatic amputation globally, yet most are preventable with timely intervention. So who is at risk? Multiple factors increases the likelihood of developing a diabetic foot ulcer. You all know, still I would like to take you through of it. The peripheral neuropathy, loss of protective sensation. Peripheral arterial disease, reduced blood flow and poor healing. Then previous ulcers are the strongest predictor of recurrence. Previous amputation is also, that is what I just said, at a higher risk. Then foot deformities, high pressure points and abnormal biomechanics. So biomechanics is what? It is basically the weight or the pressure that falls on the foot. Then poor glycemic control, impaired immunity and delayed wound healing. So sign and symptoms, there are other colleagues who had already spoken. Still I'll emphasize on this because this we need to be reminded again and again on it. So early warning signs, if you look at it, numbness, tingling or burning sensation, and a dry, cracked skin and thick calluses, foot deformities, and change in skin color or temperature. Now, active ulceration, if you look at it, open wound with drain or exudates, and swollen redness or foul odor, pain or signs of localized infection, promote recognition, enables early treatment, and significantly improves outcome. So there is a tool over here, Wegener tool. This tool is actually used for classification of diabetic foot ulcer. So we should know at what stage what is happening. So as I was saying, I had put it as 0 to 4. It is 0 to 5 basically. Look at that. I'll just take you through quickly through this scale. So grade 0 is actually no ulcer is present, but the foot is at high risk. There is a risk. But high risk foot, deformities, calculus, and healed ulcers, these may be present. So at high risk foot, prevention is the key. Grade 1, superficial ulcer is there involving only the skin. So good healing potential are there, so time is still there, we can still take care and heal it. Grade 2, deep ulcer extending to tendons, ligaments, joint capsule or fascia. So deep ulcer needs aggressive care. Grade 3, abscess or osteomyelitis can be seen, or joint infection also can be there. So infection present, high risk for complications. Grade 4, localized gangrene. So here you can see forefoot or the heel can be affected, but it may need amputation sometimes. Then grade 5, if you look at it, extensive gangrene involving the entire foot. Very high risk for major amputation often required. So why we have to use this tool? To assess severity, guide treatment, monitor progress, predict amputation risk. So for the bedside nurses, as we say, you are the champs who are bedside doing this. For your easy remembrance, what you can do, just look at 0. Remember, it is risk. Look at 1, meaning involving skin. Look at 3, there is infection. Look at 4, local gangrene. Look at 5, whole foot gangrene. So these are the things that should strike, so you can go deep into it and you can find out exactly what is happening. So early assessment saves feet. So management, a multidisciplinary approach, where of course you are already doing the wound assessment, already previous speakers also have spoken. So wound assessment, where you can look at the size of the wound, depth and the tissue viabilities. Then debridement part of it, you can see removal of non-viable tissues to promote healthy healings. Then infection control, of course, definitely once the appropriate antimicrobial therapy is based on the culture report, as doctor advised, we need to carry out. Offloading, pressure redistribution using specialized footwear or a device, and glycemics optimization, tight blood glucose control to support human function and healing. It is very important. Then patient education, most important of all. We also, at times, if any of us are going through any kind of health issues, we also neglect ourselves. Then think of the patient who gets fed up of trying to take care of himself. So here comes the very important role. So I'll show you in the other slides. So a coordinated, comprehensive approach can give a better outcome, fewer complications, improved quality of life, and holistic patient care. Prevention, the dynamic approach. Stop it before even it starts. So here you see the prevention is the most effective strategy for reducing the diabetic foot complication. A dynamic approach combines continuous assessment, education, and proactive care. So here we can tell the patient daily self-inspection can patient do. Check feet daily for cuts, blisters, redness, or swelling. Use a mirror if needed. Then proper footwear. It's very important. We never tell diabetic patient you cannot wear any footwear. That if you wear, what will happen? So here also you need to educate and tell them. Wear a proper fitted shoes and clean socks. Never walk barefoot, even indoors. While we are at home also, we just walk casually, feeling very comfortable, but you don't know what is the next risk that occurs. So glycemic control, maintain target blood glucose level through diet, medication, and monitoring. Regular checkup, very important. Schedule routine foot examination with a healthcare professional for a early risk detection. So small step today, healthy feet tomorrow. So wound care protocol step by step, you all know. I'll just mention the main heading: assess, clean, debridement if need to be, debride, take out the slough, the dead tissue, whatever is there at dressing. Even the physician is there at bedside, the RMOs are there if they're doing. If you are also doing, if you're an expert wound care nurse, you also can do. Dress with suitable moist dressing and offload it. So health education has to be in two aspects. One is to the patient and one is to the family. Why? Because patient may forget. Patient is all the time physically, mentally, emotionally, maybe traumatized. Patient may not be able to remember all time having this kind of problem within him. He or she can see it with the open eyes, what problem is going on, that uneasiness feeling. So what happens? This is the role where the family members can play with the patient. So help. Inspect feet every day, as I already said, by using a mirror. Never cut corns. Very often you will find patients taking a blade and trying to cut the corns. Oh, this is sticking out, let me cut it off. Ita bata hocche na. These are the things, but that should never be done, has to be educated on. And then see a podiatrist if the need be is there. And test water, meaning while going for a bath or trying to wash himself or herself, test water with elbow but not with feet. Wear shoe at all time, even indoors, and report any wound or a sore immediately. Take all medication as prescribed. They even try to miss the dose sometimes or forget their dose. So this is very important. We have to make them aware on that. Then attend all follow-up appointments. Stop smoking. It cuts blood supply to the feet. Patient, family, how they will help. Help patient with a daily for inspection if they can't see or bend. Ensure patient is always wearing a proper diabetic footwear. Monitor blood sugar level. Together support adherence. Then learn the signs of infection, redness, warmth and swelling or odor. Then accompany to medical appointment, ask questions if there is any doubt related to the patient's care at home, and provide emotional support. Diabetic foot ulcers affects mental health of the patient too. Know when to call emergency device or rush to hospital. I have in a slide, I'll show you that also. Then there are do's and don'ts. So when patient goes home, we can give a little leaflets like this or a reference card or things like that, where patient with this pictographic format can look at it, may not know how to read and write, or may even know, but at least looking at this colorful leaflets will give them a diversion of mind, and they will feel like, okay, this has to be done. So this also can be given to the patient. So healthy feet, happy life. Care today, avoid complication tomorrow. This will help the patient to check daily, protect always, consult regularly, control better. When to seek immediate medical help? So I have put it into 3 categories. Emergency, meaning the patient has to go to ER immediately. When? Foot wound is with fever, more than 38 degrees centigrade, then rapid spreading redness, or black or blue discoloration of the toes, severe swelling with extreme pain or foul smell from the wound. This is the time when the patient will go directly to emergency. Urgent. Urgent means it's on the same day. So what you can do is, new wound that won't stop bleeding, signs of infection, pulse, increased warmth, wound larger than 2 centimeter or 0.8 inch, then wound exposing bone or a tendon, then swollen lymph nodes in groin or leg. This is the time where patient go on the same day and see the doctor. Soon, that is within 48 hours. So book an appointment. When you will go, any wound that doesn't heal in 2 weeks, new blister, cut or a sore on foot, change in wound, appearance or odor, then new numbness or color change in foot, ingrown toenails with skin breakdown. This is very important. Act early, heal better. So key takeaways. Diabetic foot ulcers are largely preventable with education and early detection. A multidisciplinary team is essential for effective management. Patient empowerment through self-care reduces mobility. Timely intervention preserves lip function and quality of life. So prevent, detect, act, protect. Together we can prevent diabetic foot ulcer and build a better tomorrow. Thank you.
Thank you very much, Sujata. You have enlightened us with, very specific topic, and with very good scale that you have shown. I think everyone got the understanding. That's a lovely, scale which she has picturized, as well as given us the knowledge as well as the intervention. But we all know often it is very difficult to convince the patient, those who are having high level of sugar, to even a dietitian prepares a big chart and asks them that you follow and measure your food, your rice, your all the material with 20 gram or 10 gram or 30 gram. Hardly people follows, whenever a dietitian writes that. And all the delicious foods which are available all around, that attracts them and they takes. But when they comes to doctors and nurses or in diabetic clinic, they say, no, we did not have. So we don't know why this kind of neuropathy or the wound has developed. So here nurses play a very pivotal role of counseling the patient, and not to have those which will be harmful to their health and the wound. If you find the wound has already developed, and how to take care, how to manage, and what type of clinical education that need to give to a patient. So thank you, Sujata. And as she spoke about the amputation, which is the last stage when we really have to counsel a patient for go ahead, and the phantom pain that a patient complains often, and there are lot of counseling
and such kind of agony and painful state of the patient when we see after amputation, nurses play a great role of counseling the patient. Thank you very much, Sujata,
Thank you so
for
much,
your
ma'am.
enlightening
Thank you.
talk. And without spending any more time, as we are running a little short of time now, not much, but still I will call upon. Thank you, Sujata. You can just sit here. Yeah. I would like to now call our Sharmishta. She is ostomy nurse and she has a vast year of experience. She is working in Tata Cancer Center. And we are fortunate to have Sharmishta, and she has got recently an opportunity to go to an abroad. You are going somewhere, no, Sharmishta?
Yes, ma'am. It's an international conference in Istanbul.
Oh, great, great. So all the best for that. And she has given numerous lecture also during her career life. She is running very well the Ostomy Care Center at Tata, which is developed by Madam Abanti, and this is running full-fledged. Many of the nurses, I think, Sharmishta, you have trained to get the certification on colostomy care. So that's a great job that you are doing. And she is providing extended care to patient as well. So there are a lot to learn from you. Thank you very much. Over to you, Sharmishta, with the negative pressure in wound therapy, pros and cons. Thank you.
Good afternoon, everyone. Thank you, Madam Dolly Bisher, and everybody present here, and BCCI definitely for giving me this opportunity to talk over here. And you know, I'm very much opportunist because Madam Abanti, my idol, is sitting here, and I'll be talking in front of her. So definitely, I will try to give my best. There is a quote: "Every wound tells a story, but every wound does not heal easily." So the negative pressure wound therapy transforms the complex and chronic wounds in managing from the very periphery to a very modern technique. So we will discuss in today's session how it works and how it transforms the wound from the very open one to a closed one, and what is the nurse's key role in taking care of the patients with a chronic wound. So the contents today we will discuss is the mechanism, how it works, the indication, when we can do the modern technique, the pros and cons of the NWPT, and the best practices, what we can practice. So what is NPWT? It is, I think, from the today's morning session, we were discussing the modern technique, NPWT. It's a wound management modality applying controlled sub-atmospheric pressure to the wound bed. It uses the sealed dressing connected to a vacuum pump and canister. The goal is to remove the exudate, that is the main goal, to reduce the edema, which is a load on the wound, and which is reducing the closure, and to promote granulation and wound correction. The mechanism of action of this technique is, the main three action remains mechanical effect, cellular stimulation, and the fluid removal, that is the main goal. So the mechanical effect is, it applies controlled negative pressure to the wound, causing wound contraction and the microscopic tissue deformation. So the main purpose of our any dressing is to raise the microgranulation there. Means that there will be epithelialization. That is the goal of our dressing. So this technique is enhancing that one only. So the cellular stimulation, how it works, the mechanical forces activate cellular signaling pathways that promote the cell proliferation, that is the cellular proliferation, migration, and the differentiation, leading to the faster tissue regeneration. We have seen a chronic wound which is for 6 months it is not healing, and we have applied this technique, and within 1.5 months it healed. And practically we have seen this one. The fluid removal remains the main mechanism of action. It removes the excess exudate from the wound, reduces the edema from the wound bed, and improves the microcirculation. And if there is microcirculation, definitely there will be oxygen and nutrition so that the wound gets healed. So the core components of this technique is, we have to take a foam or gauze dressing, that is definitely a sterile one, to fill the wound cavity. You know, whenever we do the dressing, we select a wound which is a grooved wound. Be it a pressure ulcer, or maybe it's a surgical wound, it can be a diabetic foot ulcer, or any wound. When it's a very groove wound, infected, contaminated, there are lots of exudate. Then only we are doing this technique. So we will use a foam to fill up the wound. Semi-occlusive drape for airtight seal. You see the picture? I have given a picture. I have taken a session on a dummy for the students. That picture only I have given here. You see, I have taken sponge here. It's a sterile sponge, and the airtight seal is there. Tubing to pump. There's a tubing to pump the collection to the canister. There will be a canister. If we are using any conservative material from any company, there will be a canister and a machine. We can do some, jugaru kind of technique also to reduce the cost of the patient. In hospital, what we do, we use a sterile gauze, sterile gumji, sterile, sponge from the CSSD. And we take the suction catheter, and we attach those dressing to the suction catheter. It reduces patient cost also, and definitely we have seen it has a very good result. And the optional installation system for periodic irrigation. If we are sending the patient to home, definitely we have to attach with this one to the canister. So how it works? First, you have to clean the wound. Definitely with the normal saline. We can use a betadine also if it's the infected wound. But we should know that betadine reduces the epithelialization. So if it is infected, we will use betadine, otherwise only normal saline for the cleaning purpose. If there is any scar, we have to debride also that one. Then you see the second picture, we are giving a sterile sponge here to fill the wound. But I do in practice, I put a wet gauze on the wound bed first, then I put a sponge, because I don't want the sponge to be in the direct contact with the wound. When after 3 or 4 days I will remove the sponge, there will be capillary blood vessels. There will be tiny, tiny cells. Epithelialization will be there. So when I'm removing that one, there will be a bleeding. And that is painful also. To reduce that one, I'm using a gauze, wet gauze. And then a airtight seal, transparent one, to cover that one. We have to make it a sterile one, and definitely this dressing should be under a still sterile technique. Then we have to attach it with the suction catheter. That will create a vacuum, but the pressure will be, if it's an abdominal wound, that will be 125 to 150 millimeter of Hg. If it's a diabetic foot ulcer, we have to keep it within 120 mm of Hg. If it's a bed sore, again, up to 150 mm of Hg, we can choose. Then that will be attached with a machine, which is giving the pressure. If it's a wall suction, then in wall suction. And there is a canister, you see, the sixth picture. So this canister is taking all the exudates, and we have to definitely observe in every shift which color of the exudate is. If it's a pus, if it's a muddy color one, that is okay. But if it is a bloody one, definitely you have to see maybe there is a injury in the wound, okay. So indication, very common indication is the open abdominal wound. In our setup, we are practicing on the plastic surgery, GI cases, and most of the time, gynae cases also. Surgical wounds, incision require proper closure and care. That's why we are choosing that one. Traumatic wounds, definitely. Diabetic foot ulcer, very common indication. Skin grafts in plastic surgery case, we can use that one. In burns also, we can do this. Venous leg ulcer, and then pressure injuries. If it's a grade 3 or grade 4 stages of pressure ulcer, we can choose this one. Indication, a very common one, diabetic foot ulcer. You see the picture, this picture is not our patient. Because I haven't taken the consent, I cannot give a patient's picture directly. From the Google only I have given. So in diabetic foot ulcer also, how they are using the NWPT, you see. In surgical wound dehiscence also, if the wound after closure, it opens, and in the secondary intention also it is not healing, then only we will choose this technique. And the pressure injury also, we can use this one. So the advantages, that is pros of the technique is the faster wound healing. That is the main purpose. It removes the excess exudate from the wound, reduces the edema, improves the blood flow to the wound, decreases the dressing changes. We are doing this one every 3rd or 4th day. So that reduces nursing work also. And less you are handling the wound, you are giving the scope to heal. Every day, every shift, if you are doing the dressing, there will be less healing. Controls the infection risk as we are dealing very less. Enhance skin graft success and shorter the hospital stay. With this one, we can send the patient to home also. Every 4th day, patient can come to us and do the dressing. Or in home also, they can do this one. So disadvantage, that is the cons of this procedure. Pain, definitely. Whenever you are doing the dressing or removing the sponge, there will be pain. Bleeding if we are doing any injury. Infection can happen if we are not practicing sterile technique properly. Complications like fistula and tissue erosion also can sometimes happen. Device dependency. If we are using this one with the different company canister and all, that is a device dependency. Again, in hospital, very immunocompromised patient, maybe patient cannot afford, very poor patient, we can using wall suction and all. That is also a dependency. Patient's mobility reduces. Cost also a factor. It enhances the, the cost is very much high. It charges high. Limited mobility for the patient and skin irritation. That plastic dressing material, airtight seal we are putting, no. Some patients are having allergy with that one. So, and from that removal technique also, there can be a skin peeling and all. So the contraindication when we should not use this one, if it is an untreated osteomyelitis, in those cases, we should not use. If it's a malignant wound. See, I have already told we are practicing in the cancer hospital. Now I am saying in the malignant wound, we should not use. When we are doing, when the patient is disease-free, but the surgery is not successful, maybe the wound is not healing, that time we are choosing. But if it's a cancer wound, the wound is, pus, and there are tumors, we are not doing this one. Necrotic tissue with extra, if it is there, we should not do this. Exposed major vessels or organs in the wound, we should not do. Active uncontrolled bleeding, if it is there, we should not do. And certain fistula cases also, we should not choose this technique. The complication, 50% cases, bleeding definitely will be there. In 50% cases, pain and discomfort we have seen. Infection happens in 10% cases. Peri-wound skin damage in 10% cases. This is the data of 2023. In Indian data, 10% cases fistula formation happens. Retained foam fragments in 10% cases, it has been seen as a complication. In 10% cases, loss of suction and therapy failure also remains there. We have seen we are putting the suction, but the sponge is not shrinking, means suction is not working. 5% cases dehydration and fluid loss also sometimes happens. So it's a study example in a journal, Cochrane Database of Systematic Review. The title was Negative Pressure Wound Therapy for Treating Pressure Ulcer. What this study says that the results suggested NPWT may accelerate the reduction of pressure ulcer size and severity, decreases pain, and reduce the frequency of dressing changes. However, the evidence regarding complete wound healing, adverse event, and cost effectiveness remains limited, indicating the need for further high-quality studies. If you go through journals, you will be getting different studies are there. Worldwide, this technique is accepted. So take-home message from my presentation. NPWT transforms complex wound and healing wounds through effective exudate management, enhanced perfusion, and accelerated tissue generation. Thank you.
Thank you very much, Sharmista. Very nicely you have narrated the entire, topic. Negative pressure wound therapy, we know that now very commonly used. Patients we are receiving with pressure ulcer, which we call community acquired pressure ulcer, and then immediately consultant refers, and the companies, the industry partners, they are providing the material, and people comes from outside and uses this particular, attach the canister and pressure. But nurses needs to understand that whether really the sponge is working well or not, the pressure is adequately there or not, and our nursing professional must learn how to connect, how to attach, how to regulate the pressure, how to understand whether really the patient is getting appropriate, desired result out of this particular negative pressure. You have explained very well each and every aspect, pros and cons that our nursing fraternity should understand in detail. Thank you very much, because every hospitals are using, but knowledge on these therapies are quite limited still, which we observe and see. So your topic, your session, really it has helped us very much to understand in details. Thank you very much.
Thank you, ma'am.
Thank you. If you have questions, anyone, you can ask and clarify. Definitely.
One dressing we can keep for 72 hours, but sometimes we can keep it for 48 hours also on the basis of exudate amount. If the
Yes.
exudate amount is very high, we have to do it every 2 days intervally. Otherwise, 72 hours is quite okay. That reduces nursing work also and reduces infection load also.
But we see nowadays, Shampa, even for 5 days continuously, the canister and the dressing is there, and after that only they comes and removes it, and there are a very good
Yes, ma'am.
healing
If the
takes
exudate is
place.
less, we can keep it for more
Yes,
also. But
yes.
exudate amount is the main thing we have to see.
So that observation is very important with the negative pressure therapy. Thank you. Thank you. So now we'll go ahead. Please take your seat. We'll now go ahead with a very important topic, heel ulcer. When unnoticed into damage, and how to prevent and manage this heel ulcer. So with us, Professor Dr. Mohua Kormokar. She is the nursing superintendent cum professor, Jagannath Gupta Institute of Medical Science and Hospital. So Mohua, over to you. Mohua is having also quite, years of experience in the field of nursing educations and the clinical. And Mohua have done her PhD, completed her PhD from Malaysia, right?
Yes, yes.
And she has gotten a vast experience. So we will listen to her today with heel ulcer. Thank you.
Thank you, BCCI, for giving me this opportunity. The speakers, I am enlightened, and Dolly Madam, she is ocean of knowledge, so I was a little scared before that what I should speak. Then I understood that if I miss something, somebody is there to hold my hand. Yeah, thank you. So to the topic, when I saw the distribution, it was first topic is foot ulcer. Then my topic is prevention of heel ulcer. So heel is also part of foot. So I was thinking, what special I have to tell on the foot, because I would be standing in between the lunch and the session. So I have to be very pinpointed. Now, unnoticed, it gets damaged. And why particularly heel is so important? When we look into the anatomy of the heel, the calcaneus, over that the fat and the muscle is less. So it makes it more prone to the friction, and the compromised blood flow also occurs because our body weight is on the heel. So since it is uniquely vulnerable among the whole foot, we need to have more attention to prevent the heel ulcer. Without prompt intervention, superficial damage can escalate into deep tissue injury, osteomyelitis, or severe infection requiring amputation that she has already told. So heel ulcers, most commonly present as diabetic foot ulcer or pressure ulcers, both require our nurses' aggressive, protocol-driven management. When we talk about prevention, since I am from academics, also now into the clinical side, for prevention, these are the tiers of prevention. If I keep aside primordial prevention, then comes the primary, secondary, and tertiary. Now, when we go into the primary prevention, first we need to know what are the causes. Already the causes are discussed by Shrujata Madam, that sustained pressure and immobility. This sustained pressure and immobility can be when the patient is in the IPD, is bed-bound or wheelchair-bound, where the immobility compresses the heel tissue. There, the IPD nurses has a role. The primary cause of heel ulcer can be diabetic neuropathy, because the patient cannot feel, the sensation is less. So when it goes to the community, we have now the practice of barefoot walking is less, but then the injury to the feet may happen, and mostly because the sensation is less, the injury can happen where the patient doesn't know. I'll cite an example where my husband from Bombay sends a picture to me that the auto driver got heel injury or heel ulcer. The picture, like from AI, we cannot assess what is the picture. He told that it seems like a cone. But then, being a nurse, just it seems like a cone was not my answer. I said, I think it is more than a cone, and he has to go to the healthcare facility, and maybe it is due to diabetes which remained unnoticed. The heel ulcer in the community, not in our hospital, in the community, we don't regularly check our blood sugar. So, unnoticed blood sugar remains, and the heel or the feet gets injured. From there, the wound starts. So, as I directed him, where the community nurses or the OPD nurses also have to assess this or act this to prevent heel ulcer, is that when we directed, we found that yes, the blood sugar level was very high, and that's why the wound was not healing. He was diagnosed diabetes then. From HbA1c was 11. So this can also happen. Poor circulation, which is already told, friction, shear, and moisture. Now, repetitive rubbing of the feet, dragging forces, which happens by the malhandling of the patient while we are changing the position in IPD, or it may be due to the faulty footwear. Now, recently I heard that for Crocs shoes, which are very high priced, it starts from, I think, 3,000 or something more, and people flaunt Crocs. Crocs is having a lawsuit where it is not natural rubber, and from there, the heel ulcers are developing. Now, so we have to choose our footwear properly to prevent the heel ulcer. Then trauma, direct trauma, or unnoticed foreign objects can initiate ulcer formation. Now, this is the community prevention. In the first session, Dr. Agarwal said that we are sending the patient back to the primary health centers. There the need is there. For prevention, it is the tier system where the health supervisors, they are there to assess, to educate the patients in the community. And when we talk about community, we encapsulate our mind that it is only rural India. Community is not restricted to rural India. It is also in our urban. Now, I am working in a hospital which is neither private, totally corporate. It is private, not totally corporate, and not public. It is in between. We get patients of Shastro Shati, we get patients from Ayushman Bharat, and also deluxe patients. There we got a patient who, elderly patient, after getting pedicure, got heel ulcer. Now, we are fanatic about our heel, right? We females who are little well-to-do, we need to access them also in the OPDs and let them know that when you are going for pedicure, the temperature of the water is also very important. You are dipping your feet, but you don't know. Since you are diabetic, your sensation is compromised. You need to assess with your elbow. So these are the nurses in the OPD nurses in the IPD, also in the rural side, we have to educate. And thanks to Ayushman Bharat, the CHOs are introduced and they are doing wonderful job. They are doing jobs apart from what they should be doing. Still, they are bridging the gaps. Now, patient and caregiver education is daily foot care. I was earlier in Peerless Hospital, where in the diabetic clinic, the first thing they will ask me was, open your shoes, open your socks. Somebody is there to check my feet. And I was complimented that, yes, your feet looks beautiful. No. So, yes, you have to look for that beautiful feet. You have to. In the OPDs, you have to check whether there is any sign. Then we can prevent. Hygiene and inspection is very important. Footwear and protection. When we come to footwear, we say you wear covered shoes. When we say wear covered shoes, we don't add that you wear socks with the covered shoes. If we are not adding these socks with the covered shoes, the patient already they are having a feeling that with the socks we get heat in our feet. We don't want. But then the sweat is inside the shoes, and with a small crack in your heel, you are prone towards the infection. So when we are educating, these are very minor things that we have to tell, but we have to tell those things. Nail and lesion care is very important. And the medical management, madam has told that we have to maintain the blood glucose level, the target glucose level. In the OPD, the clinical examination, I gave you the example, the wound evaluation and the diagnostic and imaging. In the IPD, madam has given such a beautiful tool. Apart from that, also we are using Baden scale, and if the wound is already there, then we can use this push stool. And for the prevention, which is discussed for diabetic foot, the heel is not anything extrapolated portion of the feet. It is same, and the heel suspension is needed. The pictures were nicely used in the first presentation. The protective booties, daily inspection by the nurses, and the support surfaces every 2 hourly. So management is actually strict offloading when the patient is in our care in the IPD. Infection control protocols that we have to maintain. We are having these IPCNs to take care of this. The wound bed preparation, madam also told so nicely about the vac therapy and the healing support with proper nutrition guide. So, key takeaways: assess early and assess often. In primary prevention, we are assessing, we are finding out who are prone to, and early detection is very important, and we have to do it frequently. Whenever the patient is coming to the OPD, we have to do. Whenever the health supervisor is going to the community, to the homes, they have to do. Offload relentlessly. Never disturb any stable posture. Like the one picture which was sent to me, they felt it is gone, they cut with the blade first. So we need to educate that any wound, we are not going to touch it ourselves. And empowered patients. We are not there always. We have to empower the patients and the community and the family members to take care of their beautiful heel. beautiful feet. Thank you, Anna.
Thank you very much, Mohua. Yeah, you have taken a very important session, and we know that when a patient bedridden or having, for long period of time in the hospitalization state, at that time, in charges play a very important role. While the nurses are doing an head-to-toe assessment, often they fail to assess the heel status, and there the patient develop heel ulcer. There are shift in charges, they must check at least in 24 hours once the whole thoroughly, the entire head to toe, and assess the heel status and guide their staff accordingly. There are many commercial products, preventive dressings are available, and to release the pressure or to offload the pressure, there are customized heel elevators which are available that can be used, and so that the pressure can be offloaded from the heel along with the preventive dressing. And the Arjo Conclave has manufactured this Maxi Move, which will always help the patient to release the pressure not over from the heel but from the entire body when patient have been taken out with the help of a Maxi Move and move adequately, so that these kind of pressures can be released from heel and from all the pressure point. So those products and those preventive measures should be taken up to avoid such kind of ulcer or wound from the patient's pressure point. Thank you very much. I think we have come to the end of this sensitizing session. Thank you, Mohua. Thank you, Sharmishta. Thank you, Sujata, for taking up this session. Now over to Sharbani. Okay. Yes.
Yeah. Ma'am, actually, yeah.
You can just turn to the
Yes,
audience.
yes. Actually, earlier Waterloo and Braden scale were used in UK, but nowadays a new tool for assessment is Purpose T. You can Google it, and it is very interesting tool which will give more depth, which is in current practice. Though we have not adapted, because in Indian scenario we find Braden is more user friendly. But this is also something new which...
So, Pritha, there is a Arjo Conclave stall.
Yes,
if
ma'am.
you have that tool, everybody will go there and learn what is the tool all about, and you can explain as well.
Okay. Actually, ma'am, today we wanted to highlight on the repositioning as you have shared,
Yes.
but we are going to show on total verticalization and early mobilization.
Thank
which
you.
can
During
help
the
in
skillathons.
Yes, yes.
Okay.
ma'am.
Okay. Thank you. Thank you so much.
Thank you, ma'am. I now request our co-chairperson of the National Health Committee, Mrs. Dolly Bishash, to please present mementos on behalf of the Bengal Chamber to the speakers. To Ms. Sujata Angela Singh. To Ms. Sharmishta Roy. And to Dr. Mohua Kormakar. High Care Remedy, one of our industry partner has presented the registration kit for all the participants, including the speakers, a goodie bags. So I request Mr. Prashanjit Guho, the director of the High Care Remedy, to please be on the dais. High Care Remedy is also a member of the Bengal Chamber of Commerce and Industry, and I request Mr. Guho to do the honor and present mementos to Mrs. Dolly Bishash, the chairperson of this session, and also the co-chairperson of the Health Committee of the Bengal Chamber. And to please present mementos also on behalf of Bengal Chamber. Photo. I request all to please be on the dais for a group photograph. You can also, Mr. Guho, please join. Thank you. We will have a special session to be conducted by HDFC Bank. So we will take just 2-3 minutes for the changeover.
In 1, take 5. Hey, warranted. You are under digital arrest. Income tax notice है. You are under digital arrest.
ड्रग्स मिले आपके नाम.
You are under digital arrest.
Vigilante? Oh, vigilante. ये है असली अरेस्ट. Digital arrest is 100% fake. It doesn't exist. अगर कोई कॉल पे बोले यू आर अंडर डिजिटल अरेस्ट, पॉज, डोंट एक्ट, वेरीफाई विद द नियरेस्ट पुलिस स्टेशन और योर बैंक. ऐसे और भी फ्रॉड्स की जानकारी के लिए विजिलेंटी को फॉलो करें.
I now request
In 1, take 5. Hey, warranted.
please be on the dais. I request Mr. Muhammad Ibran from HDFC Bank, please be on the dais and present the session.
Good to go? Good afternoon. I am Mohammad Imran representing HDFC Bank this afternoon. A warm welcome to all of you. I will be covering an interesting subject or a product of the bank where most of us are already having or would be having after this session. I can see most of our channel partners which are there present this afternoon are already banking with us and having or availing this product already. Charnock being one of them and Narayana being the other one. Park Hotels, where we are sitting at this point in time, is also one of our channel partners. So what is in for all of us is what I'll cover in this session. So HDFC Bank, as you are aware, is having more than 9,500 branches, more than 21,000 ATMs, and is present in all cities across India. As for our reach with products, we are doing, or we are number one in terms of personal loans, in terms of credit card and auto loan business. So, of course, most of the hospitals or nursing homes or institutions have relationship with us. So what is the difference that we are making in the lives of all our employees, nurses, staffs, whatever you call them all? So the first thing is not only that we are offering a zero balance account to the primary holder, we are offering a zero balance savings account to the entire family of the primary account holder. So for example, if I am an employee of any of the hospitals or nursing home, my entire family can bank with HDFC Bank under zero balance banking program. And all of my family members will also get a complimentary debit card like the primary account holder. and all of them will have a personal accidental death cover of 16 lakhs. So, apart from the zero balance banking facility for self and the family member, we also give insurance coverage, a personal accidental death coverage to the employee and their family. So for the primary employee, it is up to 15 lakhs, which means that 5 lakhs is on the account level. The breakup of that is 5 lakhs on the account level and up to 10 lakhs on the debit card. Similarly, for the family member, we offer 16 lakhs of coverage, wherein 1 lakh is on the savings account, zero balance savings account, and up to 15 lakhs is on the debit card. Both the family and the primary account holder, both are covered under this program. Apart from that, what we give is complimentary debit card for both family members as well as the primary account holder. We give complimentary insurance, personal accidental death cover to both. We also have a facility of zero balance banking for the entire family member, and on top of that, with different institutions, we have arrangement where we can give a unlimited debit card access to different ATMs. So coming to debit cards, what is in the debit card? Instead of charging or taking annual fees from you at the time of joining and renewal, we will instead give you 400 rupees cashback every month, which is a total of 4,800 in a year. So when you avail HDFC Bank debit card and use it, you can get 5% cashback on online spends on our platform, PayZapp and SmartBuy. You get 2.5% cashback on the spends made on other online platforms and 1% on the point of sale platforms. So debit card in itself is a product, and most importantly, we give a 4 lakh rupees zero liability coverage. What is zero liability loss coverage? Is that in case your card is misused. Many a times we have heard from friends, relatives and associates, and even at a workplace, that one of the card of one of the colleagues has got compromised and there has been money which has gone out of the account. So what happens in that case? In HDFC Bank, you just call the customer care, inform that you have lost the debit card or the debit card is in your possession and there is a mishap which has happened in your account using the debit card. They will seek few informations from you, and you have to be sure that you have not compromised the CVV, the OTP, the card details or the PIN, etc. And in 21 days, you will find the entire amount which has been misused will come back to your account. What is in, if you open the account with us, the first 30 days of opening the account, we are offering 2200 vouchers to you for availing any 5 of the 10 services of HDFC Bank. The services starts from a UPI transaction, a net banking, a mobile banking, a PayZapp, a chat banking activation. So even if you see that you don't have to buy a product to avail this 2200 benefit, you can get this benefit by simply activating yourself on different platforms of the bank. Expressway is our, you can say, way of being present in your institution. So you need not go to the bank for all transactions. Most of the transaction, except for cash and locker, you will find all the transaction services available under Expressway. So under Expressway, you can scan the QR code. There is a QR code which looks like this. So you can scan the QR code, and thereafter it will take you to this kind of a page where you can do all the service requirements of yours. For example, mobile number updation, email ID updation, nominee updation, even signature updation today can be done sitting at your office or home in 10 minutes. 7070022222 is our WhatsApp banking number. You can get all your services of accounts, credit cards and loans through the WhatsApp banking services. So as I was mentioning in one of the points, that we have our own proprietary payments app You must have heard about the PhonePe, the erstwhile Paytms and GPays of the world. But this Pays app is HDFC Bank proprietary. What does it mean? That this is managed and handled by HDFC Bank. It is one app, maybe developed 8-10 years back, when we were saying that in this app we do not divulge customer information. That means the account details, the credit card details, the debit card details does not flow to the merchants. So those were early days. Today you can scan and pay, do UPI transaction, transfer between your own accounts, pay all kind of bills using the PayZapp app, and this is one of the most secured app that is there present in the market. And not only that, by using the app you can earn up to 12,000 rupees cashback a year. And today, I'll say most of the ladies, I can't see most of the gentlemen, so I say ladies, this is a lifestyle on the right. So that is a lifestyle, and when you are using on these platforms, anywhere between 5%, maximum 5%, you get cashback, you earn cashback by paying through the PayZapp app. Swiggy, now most of us will agree that today our kitchen is Swiggy, right? So grocery items, your kitchen items, food, and there is one more on the platform which is wines. I don't know how many of us have the taste, but all three items which are there on Swiggy platform today, you get additional 10% discount. So say for example, your bill is 10,000 rupees a month. Today you are paying 10,000 rupees. But if you take the co-branded Swiggy card from HDFC from us, then you additionally get 10% discount for all the bills that you pay, all the purchases that you make. So end of the month, what will happen? Instead of paying 10,000 rupees, which you are paying now, from next month, once you avail this card and make the payments to this card, you will have to pay only 9,000. So the final bill will be like 10,000 less 10% discount, pay only 9,000 rupees. That is Swiggy card for you. Loans, as I said, HDFC Bank is leaders in personal loan, auto loan, and even two-wheeler nowadays. So for loan services, we have the best turnaround time. The best turnaround time, the loan gets disbursed in only 10 seconds. A personal loan in HDFC Bank, if you are having an account with us, can get disbursed in only 10 seconds. And as I said, this is a world record. This, an Indian bank, having a world record to disburse a personal loan in 10 seconds. Earlier record was held by a Polish bank in Poland, but we have replicated and brought that technology to India in almost 10 years, and we hold the record to disburse a personal loan in 10 seconds. No documentation required, nothing required. You click on the banner, confirm, and in 10 seconds, the money comes into your account. Yes, car loan, two-wheeler, we have replicated the same. We do 10-second disbursement on car loans. We do 10-second disbursement on two-wheeler loans. Only difference between the personal loan and the car loan and two-wheeler loan is in personal loan, the money comes in your account. In two-wheeler and car loan, the money goes to the dealership, which you select at the time of disbursement. Many of you will be doing few investments in life. So we have a discounted broking platform. If you have heard the name of Zerodha, Upstock, and Grow, this is an answer from HDFC, our group company Securities. 20 rupees is the flat brokerage per order. So irrespective of the order value, 20 rupees is the flat brokerage. We have the lowest MTF in the market at 12%, which is lower than any other discounted broking platform. And from the first year, there is no AMC. From the second year, the AMC is only 20 rupees per month. Coming to Smart Wealth, if you are an HDFC customer, you can download this. You can invest as low as 100 rupees per month in SIPs with us. And for that, there is no charge, no fee that HDFC Bank takes from you. So all your investments into mutual funds can be routed through Smart Wealth, and for that you don't pay HDFC Bank a penny. So that is our complimentary services. And again, as I said, whatever investments you have in the industry today with different registrars, you can consolidate into this one app and manage it from Smart Wealth. We have a base insurance coverage also offering from Bajaj, who is our channel partner, and for that you will have to take a policy which is for self or with spouse or children, as the combination may be. You can take a base plan with us from Bajaj. You get OPD coverage also in that. But this one is a hot cake. Now, why I say hot cake? This policy is only exclusive for HDFC Bank salary account customers. What does it say? It says that for an amount of 2499 a year, I'm repeating, 2,499 rupees, 2,499. If you pay in a year, you get a super top-up coverage of 30 lakhs with 3 lakh deductible. I don't have to explain to you what kind of hospital bills come nowadays for patients. So that my job is cut. Now the second part of it, how do you pay? So if you have this plan with you, basically you are risking or limiting your liability to 3 lakhs, because the first 3 lakhs is my baby. It is the part which I need to pay. Thereafter, Niva Bupa comes into picture for the remaining 30 lakhs. And this is not only for myself, it is for my spouse and 2 children, maximum age between 91 days to 21 years. So the entire nuclear family, you can say, can get coverage of up to 30 lakhs with 3 lakh deductible and with a paltry amount of 2499 a year. And not only that, there is an accidental death benefit for the primary holder for 30 lakhs under this arrangement. But this, as I said, is only exclusive for these salary account customers of HDFC Bank. So as I said, whatever I have discussed, I discussed about the Swiggy credit card, I discussed about the Niva Bupa, I discussed about the other items. For all these items, I have plotted a cost that you would have incurred, or the savings, in other words, which you can have by switching to HDFC Bank. So an account which you open with HDFC Bank, and assuming that you take all these services, avail all these services with HDFC Bank, for each and every account, there is a savings of 69,000 a year. So the value benefit of switching into HDFC Bank, switching your salary account to HDFC Bank, is 69,000 a year for each and every account. So I have concluded. If there is any questions, I'm ready to take questions. This is the number of my colleague Sudhanshu, who is present here only. So you can have or save his number for any queries that you have, for any kind of requirement that you have at an institution, at a hospital, at a nursing home level, or at an individual level if you want to avail any services of HDFC Bank. So the house is now open for questions. Was I that good that there is no question? Anybody at the back? Any question? It can be related, not related to the topic. Both. Okay. Sure, ma'am. Sure, ma'am. I think he's switched it off. This one, ma'am? This one? So that's savings by switching to HDFC Bank. This you wanted to see. Okay, since there's no more questions, then I'll thank all of you for your patience listening and bearing with me. Thank you so much. Have a great day.
Thank you for your presentation about your bank, and I hope you people have liked it. Now I request the observer madams to please be on the dais, Ms. Madhuri Manna and Ms. Ashmita Mukherjee, to please present mementos on behalf of the Bengal Chamber.
Under digital arrest.
Vigilante? Oh, vigilante! ये है असली अरेस्ट. Digital arrest is 100% fake. It doesn't exist. अगर कोई कॉल पे बोले you are under digital arrest, pause. Don't act. Verify with the nearest police station or your bank. ऐसे और भी फ्रॉड की जानकारी के लिए विजिलेंटी को
for the moot court for 5 minutes. In the meantime, if you want, you can visit the stalls at the back.
ये वारंट है. You are under digital arrest. Income tax notice है. You are under digital arrest.
ड्रग्स मिले आपके नाम.
You are under digital arrest.
Vigilante? Oh, vigilante! ये है असली अरेस्ट. Digital arrest is 100% fake. It doesn't exist. अगर कोई कॉल पे बोले you are under digital arrest, pause. Don't act. Verify with the nearest police station or your bank. ऐसे और भी फ्रॉड्स की जानकारी के लिए विजिलेंटी को फॉलो करें.
A place where hope meets healing. Welcome to Apollo Multi-Speciality Hospitals, Kolkata. In the heart of Eastern India, we stand as a perfect blend of advanced technology, robust infrastructure, and heartfelt hospitality. From the moment you step in, you're greeted not just by our state-of-the-art facilities, but by smiles that assure you're in safe hands. Our vision, inspired by our chairman's leadership, is to be the leading healthcare provider in Southeast Asia. A 750-bedded tertiary care facility, Apollo Multi-Speciality Hospitals, Kolkata was the first in Eastern India to earn the prestigious Joint Commission International accreditation. Whether it's the comfort of our suites or managing challenging conditions at our 293 critical care beds, with tie-ups with all major insurance companies across the world and dedicated waiting lounges, we ensure a hassle-free experience for our patients. From Indonesia to Vietnam, Myanmar to Cambodia, families across Southeast Asia trust us for our unmatched healthcare services. At Apollo, distance is no barrier to quality care. With Apollo Pro Health, a revolutionary health check program powered by expert doctors and AI, we don't just diagnose diseases, we predict and prevent them. Your health, our promise. Precision is at the core of our advanced laboratories, pathology services and blood bank. Every test, every analysis is a step closer to better outcomes for you. Our 5G connected ambulances and 26-bed monitored emergency unit are always ready to deliver life-saving care when every second counts. From state-of-the-art operation theatres, advanced cath labs, the most advanced Da Vinci Xi and Covis orthorobotic surgical systems, we ensure precision, safety and superior patient outcomes. Our comprehensive surgical complex has made us one of the top referral centres for transplants in South and Southeast Asia. Eastern India's most advanced medical equipment, CT scan, MRI, PET-CT, gamma camera, digital X-ray, high-end equipment and cutting-edge treatment facilities, all under one roof. Our oncology team combines expertise and innovation to provide advanced cancer care with medical, surgical, hemato and radiation oncology. The Halcyon system ensures that all patients now benefit from image-guided radiation therapy.
Requesting everyone to kindly take your seat. Now we will start our moot court. One of the highlights of today's conclave is the moot court presentation titled Justice Beneath the Skin. The participants are Adrita as patient's wife, Priyanka as public prosecutor, Ruchita as defense lawyer, Doyle as court clerk, Aditi as wound care nurse, Regina as a doctor, Mehak and Pubali as the accused staff nurse, and Sohini as the judge of the court. We invite the coordinators, Ms. Andrila Acharji, clinical instructor, and Ms. Dipta De, infection control in charge, Fortis Hospital, Anandapur, to take the charge of the proceeding. Requesting once again to please kindly take your seat. Soon we will start our moot court. Requesting everyone to please kindly take your seat. We will start our moot court.
আমাকে যখন ডাকবে তখন আমি ডাইরেক্ট উঠে ওখানে চলে যাব। হ্যাঁ, আবার ওখান থেকে নেমে এখানটাতে এসেই দাঁড়াবো।
Okay, so you may proceed, and this court will determine whether the standard wound care protocols were followed.
Thank you, my lord. Your Honor, first I would like to introduce to you my client, Mrs. Adrita, who is the wife of the patient, Mr. Raj. Mrs. Adrita, can you please come to the witness box?
I shall speak the truth, the whole truth, nothing but the truth.
Mrs. Adrita, can you please explain what has happened?
Your Lord, my husband was admitted on 10th of May and I kept him under their care. But still, it led to bed sore and even it led to lower limb weakness. Your Honor, please help me. Please give me justice.
Your Honor, as Mrs. Adrita has explained, Mr. Raj was admitted to the hospital on 10th of May. And at the time of admission, he had no sign of pressure injury. But at the time of discharge, he has developed stage 4 pressure injury, which has further led to tissue breakdown due to excessive wound debridement. As the evidence shows, no repositioning chart, no Braden score reassessment, delayed dressing change, and inadequate moisture management. These are the evidence we have got.
Okay. So, Your Honor, this case involves a bedridden patient who has developed a preventable pressure injury. So, we will prove at the end that failure to follow standard wound care protocols have led to tissue breakdown and infection. Okay, so is there anything to say from the defense side?
Yes, Your Honor. Thank you. That particular day, the ward was understaffed. The patient was hemodynamically unstable. The nurse prioritized life-saving interventions. We will demonstrate that the injury was unavoidable due to the comorbid conditions of the patient.
Your Honor, now I would like to ask a few questions to Mrs. Adrita. So, Mrs. Adrita, did you observe regular turning of the patient?
Sometimes, but from evening to night, he was kept in the same position for many hours.
Mrs. Adrita, was the patient cooperative?
No, he resisted turning due to pain.
My lord, please make that a note. On addition, I would also like to ask your husband, Mr. Raj, did he develop pressure ulcer before admission?
No, he had no bed sore before. He only developed it after the admission.
She is absolutely lying, my lord. The patient already had pressure ulcer, first degree
Objection,
pressure
Your
ulcer.
Honor. Objection overruled.
The patient already had first degree pressure ulcer before admission.
Okay, so is there any document?
No, your lord, there's no such document by the nurses.
Okay. Mrs. Adrita, thank you. You may have your seat now. Your Honor, now I would like to call Miss Aditi, who is a wound care nurse at the hospital. Miss Aditi, please come to the witness box.
I shall speak the truth, the whole truth, and nothing but the truth.
Miss Aditi, can you please explain what are the standard prevention protocols?
Repositioning every 2 hours, daily skin assessment, provide back care, and provide pressure relieving mattress, and also applying preventive dressing. So I think this injury progressed due to prolonged pressure and delayed intervention.
Okay, so Miss Aditi, I would also like to ask that does hypotension and diabetes mellitus worsen tissue perfusion?
Yes, but preventive measures sometimes significantly reduced risk.
Okay, thank you. Thank you.
Your Honor, now I would like to call Dr. Regina, who was the consultant of the patient. Dr. Regina, please come to the witness box.
I shall speak the truth, the whole truth, nothing but the truth.
So, Dr. Regina, can you please explain, is there any direct risk of having this kind of mishap due to any comorbidities?
Yes, my lord. The patient got admitted under me due to CVA and lower limb weakness. But that time, there was no history of comorbidities like STN and diabetic mellitus. I don't think so. Due to that, the patient got 4-degree bed sore, and at the time, patient was doing quite well.
Thank you so much, Miss Dr. Regina.
Thank you.
Your Honor, now I would like to call Miss Mahak, who was the allocated staff in the evening shift. Miss Mahak, can you please come to the witness box?
I shall speak the truth, the whole truth, nothing but the truth.
So, Miss Mahak,
Yes.
was aseptic dressing techniques followed?
Documentation doesn't show any sterile dressing compliance, but the later showed purulent discharge.
In your shift, how many times did you change the dressing?
Sorry, Your Honor, that day I had 6 patients under my allocation, and among of them 3 are bedridden and they are critical conditions, and I didn't get enough time to change the dressing when that was indicated.
And what was the Braden score?
10 by 23.
Your Honor, that is a high-risk score, and she didn't inform that to anyone. I want this point to be noted, Your Honor.
Sorry,
Miss
Your Honor.
Mahek, you may have your seat now.
Thank you, Ms. Mehak. Next, Your Honor, I would like to call Ms. Pubali, the night shift nurse of that particular day. Ms. Pubali, please come to the witness box.
I shall speak the truth, the whole truth, and nothing other than the truth.
Okay, so Ms. Pubali, please tell to the court that what happened and what was the condition on that particular day.
Your Honor, I had 6 patients under me at that shift, and among them, one patient was not responding properly. So code blue was activated at that night, and also one patient was under BiPAP, and 3 patients was bedridden. I did inform to the sister in charge about the staff shortage of the ward, and whenever it is possible by me, I did reposition to the patient.
Was risk assessment documented?
No, Your Honor.
Was escalation to the higher authority done in the written format?
No.
Okay.
Thank you, Ms. Pubali. You may have a seat.
Your Honor, how can they be so irresponsible?
Order! Please maintain silence. If you have anything to say, please come into the witness box.
Your Honor, how can they be so irresponsible? For their irresponsible behavior, my husband is playing with his life. What shall I do now? I have 3 children in my house. My husband is the only earning member of my
But,
family.
Your Honor, my client already said that there was a code blue situation. The ward was understaffed. They complained to the higher authority also.
Objection, Your
What
Honor.
did she
This
do?
is order!
Take care of the patient.
Please maintain silence. Mrs. Adrita, please you can take your seat. Wound care is a nurse's responsibility, Your Honor. Lack of documentation equals lack of care. So, Your Honor, we demand 30 lakhs as a compensation to the patient and his family and strict punishment for the nurses. Thank you, Your Honor.
Your Honor, we sometimes forget that nurses are humans too. From attending code blue situations, to attending patients, to attending call bells, to taking patients to procedures, all at once. And that too, always a smile on their face. So I would please like to request you that have mercy on my clients. On their behalf, I'm saying sorry because I feel that this is a system failure, not individual negligence alone. That's all, Your Honor. Thank you.
Okay, so this court finds that preventive protocol were partially followed. Documentation failure is professional negligence and the staffing issues are the administrative accountability. So, according to the IPC section 336, this court finds Ms. Mehak Pal and Ms. Pubali Datta the culprit of this case and seizing their registration for the 2 years. And the hospital have to pay 20 lakhs compensation to Mrs. Adrita. So, my recommendations will be mandatory on-crease reassessment training, strict repositioning audit, documentation monitoring, and the escalation policy reinforcement. So, the court is adjourned for the day. At the end, the educational message we have got that pressure injuries are preventable. Assessment.
Repositioning.
Back care.
Preventive dressing.
Applying air mattresses.
And if we maintain all these 6 steps properly, then we can maintain the tissue integrity and prevent pressure ulcer.
Thank you.
Thank you to all the entire team for the thought-provoking and engaging performance. Thank you, everyone.
Thank you. I request the audience please be seated, and I request the participants to please once again be on the dais. Participants, please be on the dais. I request Mr. Mohammad Imran, Deputy Vice President from HDFC Bank, to please present a token of appreciation to all the participants for their nice performance.
Aditi as a patient's wife, Adrita, Priyanka as Priyanka as a public prosecutor, Ruchita as a defense lawyer, Doyle as a court clerk, Aditi as wound care nurse, Regina as the doctor, Mehak as the accused staff nurse, Pubali as the accused staff nurse, and Sohini as the judge of the court. I would like to call our Miss Andrila Acharji, clinical instructor, and Miss Dipta De as an infection control in charge, Fortis Anandapur, to take the prizes, please.
I request Madhukari ma'am and Dolly ma'am to please be on the dais to do the honor.
College of Nursing and our staff of critical care areas and other area, like both are working in critical care. Regina is infection control nurse. They are the final year student. I think first year, second year, they are the final year student, no? Second year. So they have given their time from their busy schedule of collegiate program as well as clinical. From there, taking out them, making them to practice, rehearse. So it needs, a lot of time as well, and they have given their best effort to perform in front of you, and that's the scene that you have done today, and hope that in future also we will do many more such moot court, high court scene, after that Supreme Court scene. Okay, thank you.
One group photograph, please.
Okay,
All participants, please come in the front. Ma'am, group photograph. Yes. Ma'am, একটা group photograph সবার সাথে। একটা photograph সবার সাথে। We will break for lunch now.
Now we will move forward with our plenary session 2. We proceed to plenary session 2 chaired by Ms. Kasturi Mandal, Ma'am, Principal of Artix College of Nursing. Yes. Our first speaker, Ms. Chanda Bandopadhyay, Ma'am, Senior Nurse Manager from BM Birla, will discuss dressing selection in mixed etiology ulcer. We are thankful to Madam Richa Ma'am, Deputy Clinical Nurse Lead Specialist, Apollo Multi-Speciality Hospital, for being here as our next speaker, who will be sharing her knowledge, wound assessment and management based on algorithm. We now proceed to the next presentation on wound scar management by Ms. Minati Hajra Ma'am, Nursing Superintendent, Narayana Memorial Hospital. Over to you, ma'am. Kasturi, ma'am.
Hello. So once again, good afternoon to all of you. So it is a post-lunch session. Anyway, so this plenary session, actually this continuation of the first plenary session, because previous morning plenary session, it was very vividly discussed about the types of the wound, stages of the wound, management, risk factor assessment. So I will request Richa in how to do the wound assessment, because in a multitasking nursing care and the multidisciplinary environment, so inconsistent wound assessment will cause the delayed wound healing consequences like a long-term hospitalization, and it affects the economy of the patient and the family member. So we need to assess the wound perfectly and consistent manner. So I will request Richa N to highlight this area.
Good evening, Chairperson, and good evening, one and all present over here. So today I'm going to be discussed regarding the protocol and prevention of pressure injury, but it's on the algorithm process. So before we are starting this one, first we should know what is our objective. So the main objective is to protect our skin, promote comfort, and prevent the injury by implementing evidence-based clinical strategies and standardize the care protocol to ensure the patient safety and the well-being. So in order to follow the algorithm, we have to follow the 5 stages. First one is to identify the patient at the risk. Second one is to do the assessment. Third one is the intervention. Fifth one is a reassessment. Fourth one is a reassessment. And the last one is a patient family education. So let's go in detail. First step, that is to identify the patient at the risk. So we have to know which patient are having a very prone for developing a pressure ulcer. So like a patient who is on neurological conditions, like patients with a stroke, with patients with the spinal cord injuries, then patients with the conditions like dementia, then hemiparesis. This also they are having very prone. The next, not only this one, the patients with the comorbidities like the patients with the diabetic mellitus, cardiac diseases, obese patients, and along with that, patients with the COPD and renal also. When the patient is undergoing for the surgery for a prolonged time, that are also under the high risk. Then patient on the ventilator, patient with the urinary and the fecal incontinence, patients with the cast, tractions, or even with the restaurant also, they are very prone for developing pressure ulcer. Then malnourished patient and obesity, immobilized and bedridden patient. These are the category of the patient. First, we have to find it out so that we can give a more active care for them. Next one is a step 2, that is the assessment of the patient. How we are doing the assessment. We know that the burden is a standardized tool we are using in each and every hospitals. We have to do it, conduct it every time that once the patient is coming to our hospital, we have to do that one, and we have to do the reassessment also. Next one is a skin comprehensive assessment that we have to do it on the time of admissions, and within the 6 hours we have to do it. And every shift changes, every shift we have to do it. Then at any changes in the patient conditions, or we are transferring out the patient to the another units, or when the patient, at the last but not the least, at the time of a discharges also, we have to do the comprehensive skin assessment to be done to ensure the complete discharge planning. So next we will go with the nursing intervention. So nursing intervention also we are doing depending upon the risk management based on the burden scale. So we are categorizing the patients according to the burden scale to 3 categories. That is a not risk, whose the burden scale is more than 18. Then patients with the mild risk when the burden score is 15 to 18, and burden scale which is a less than 15. So according to that, we are going to do the intervention for the patients. So let's see first one, that is a skin assessment and a skin care. So in the skin assessment and skin care, we have to do the daily skin assessment. Then we need to hydrate the patient, clean with the chlorhexidine, or we can give a soft bath, normal bath also. Then avoid the pressure areas. Then we have to use the cotton, linen, so that there can be evaporation can be done from the body, sweating and all. Then apply a jelly moisturizer and use our wrinkle-free linen. Then when we are seeing to the mild risk category, assessment should be done daily basis. Then the low friction textile we have to use. We know that we have to give the bath for the patient, as well as a position should be changed every 2 to 3 hours. Then avoid the massaging when we are giving the back care or when we are giving the bath. Excessive massaging should be avoided and minimize the cleaning friction. Then we should always check whenever we are using the devices like an NIV or BiPAP, whether any ulcer has been having a chance for developing or not. Inspect under the cast. Then renal patients, we know that their skins are very dry, so we have to moisturize the patients and limit adhesive uses. When we are seeing the patients with the high risk category, we have to follow whatever we have done in the mild category. Above that, we have to use some special things like silicone dressing should be applied for the high risk area, monitor for any dermatitis developed by the patient, or avoid the diaper, maintain the hygiene, because diaper also create most of the time ulcer. Then report any rushes and apply the immunity. Next one is the repositioning. When we are seeing the reposition is that no risk patient, we have to encourage them. And repositioning every second hourly, we have to encourage them. Then avoid the position, which is a very important, that there is a position that can increase the pressure and cause a pressure ulcer. Like example, patients with a 90 degrees sitting in the lying position. The next one is a mild risk category. So in the mild risk category, what are the things we are going to do is repositioning every second hourly, use a foam pillows at the sacrum, apply a 30-degree sit, then special positioning pillows we can use it, then avoid a prolonged sitting in the chair. A maximum at least 60 minutes we can allow it, not more than that. Then ensure that when they are sitting, they should be sit in the correct posture. For the high-risk patient, frequent positioning should be increased. Previously, we are checking at second hourly or third hourly. Now we have to be increased hourly or 2 hourly. We need to check the patients. And use the devices that can lift the patients, because when we are shifting the patient, there will be a dragging will be there, then there will be a high chances of developing. So there will be a high chances of developing a skin injury. Then use a total lift bed for highly dependent patients. Then when we are giving the bedpan also, we have to provide them and remove it gently when we are removing, and we should be avoid that patients are lying down in the bedpan for prolonged time. Then elevate the heels. So we have to elevate the heels also. Heel also very prone for developing ulcer. So we have to be elevate at least a 10 centimeter from the bed by using a pillows at the cuff area. Next one is a support structure. So support structure, we are having so many support structures. So no risk patients, we use the proper form or reactive mattress, or encourage the self-mobilization every 3 to 4 hours, or encourage the side lying position when in the bed. For mild risk patients, apply active dressing gel pad in the high risk area when the PTINR is very low and when the patient falls in the moderate category. Then when you use a barrier cushion for those patients, then consider the pressure reducing, redistributing surface during the transit phase, like a foam pillows. Then apply the autologic bed weight limit up to the 200. Next, when we are seeing for the high risk category, most of the time mild category, whatever you using the same thing also we have to be used here. But above that, we have to be at some PO points. So active dressing mattress, gel patch, the body prominent. Here we have to use a Nimbus bed where we can use at least a 250 kg can be bare. Then elevation of the heel is there. Then utilizing of a lift bed, we can be recommended, and apply a silicone foam dressing to the high risk area. Avoid the synthetic sheepskin, which is a very, very important and cut-off device. Like previously, we are using the IV fluid bottle, IV fluid bag under the heels, or the gloves filling with the water, putting under the heel. This and also to be avoided. Next is we are seeing is the nutrition parts. Nutrition and hydration also plays a very important role in the development of this, nutrition for the skin. So here, dietitians plays a very, very important role. So dietitian has to do a comprehensive nutrition assessment to be done, and they have to be provided a protein, calorie, how much the patient has been needed according to their patient's plan. So along with that, when the patient's in the high-risk category, we have to be checked when the patient is having any hypoalbuminemia. If hypoalbuminemia is there, then we have to be added extra supplement has to be added, and other vitamins and minerals can be added. Along with that, hydration also we have to be checked. Hydration we have to be always checked by maintaining a strict intake and output for the patient. Next, last is that prophylaxis. So for the prophylactic dressings, we have talked so many things regarding in the previously session also. There's so many prophylaxis are there. So we have to be always use the applicable prophylaxis for the patients, and it has to be changed as per the recommendations. So some we can use for the sacrum, heels, and for the DAPI patients, we can use a multiple layers of a border heels. We can use it for the sacrum. We can use it under the DAPI for that BiPAP, NIV. Below that, we can use a multiple layer dressing can be used to release the pressure. Next one is the step 4, that is a monitoring and re-evaluation. Only just seeing is not enough, we have to do the re-evaluation also. So here we have to do a comprehensive skin assessment to be done, where we have to be checked the temperature, turgor, color, moisture, integrity. All those things we need to be assessed. And for this assessment, we have to be checked the skin area, like skin beneath and around the device, then bony prominence like a heel, sacrum, occiput, skin to skin area like an inner thigh or a buttocks, or area where the lack of sensation patient is having. And had a previous breakdown of a skin, or special attention to the patients when they are undergoing any epidural infusion or when they are having any spinal medicines. Last but not the least, for the step 5 is the patient family education. So previously session also we have talked on patient family education. So patient family education plays a very, very important role. Until unless the patient and patient relative not understand what is the thing is going on, that how much we are doing, we cannot get what we want. So we need a proper patient family education is needed. Happy has been nowadays little bit decreasing, because why we are giving the education to them, we are giving awareness to them, audit we are doing, campaigns we are doing. But when we are seeing in the copy trends is going up, because patients are there in the home, they have not been getting a proper patient family education. So when we are educating the patients, then we can coordinate each other with the patient and patient relatives, and the copy also we can reduce it. So these are some positions that we are having a pressure points and dressing. Next, we are having this is a push tool that previous also we have told we are also using the push tool for the pressure also already developed cases. In this, we are measuring the 3 criteria. This scale we are using, the 3 criteria we are using, that is a length and weight. For example, here I have shown one example that is a length and height. So the length and weight, how we are going to be calculated, the length will be the head to toe. When we are measuring from the head to toe will be the length, and the weight will be the horizontal one. So here when we are checking this one, see the length is 6 centimeters and weight is 5 centimeters. So totally it's a length into weight 30 centimeter is there. Exudate, when you are seeing the exudate over here, we are having a 3 category, 0, 1, 2, 3. In that when we are seeing it's a moderate category, so it will be a 2 score. Then the third one is a tissue type. In the tissue types, we are having a slough formation is there in the wound, so it will be a 3. So when we are calculating together, so here the first length into weight, it's become a 10, because when we are counting with the length and weight, it's a 30. So it's a more than 24 will be in the 10. Then exudate, we have seen that it's a moderate 2, then tissue type as a 3, slough is here, totally 15 is there. So when we are seeing in the graph, we have seen that like this only, so our graph intention should be always in the downward. Downward means it's a healing process. When the graph is going up, it is a worsening process. So our aim is to always make our graph in the lower side. These are the reference we have used. Thank you.
Thank you, Richa. Braden School, though it is a very commonly used and all of us have heard and we are practicing, but she has focused very vividly, and it gives really the refreshing all the points inside our thought. One thing, it is changing the positions we are doing, and we are placing the tick marks in the checklist. At the same time, we have to keep I think you also will agree with me that offloading the pressure, putting simply the pillow side of the patient doesn't create the position change. So many times we have seen patient ekdom flat ache, it is not offloading the pressure. So position changing and the offloading the pressure from the pressure point, one of the most important points.
Yes, ma'am.
Thank you, Richa. And so from her point of presentation, so if after seeing a wound, how we can do the documentation? How? So she has discussed all the points. That means whenever I will document exactly what is the anatomical place, it is the left side of the malleolus or the right side of the malleolus we have to mention. Then second point is what is the diameter.
Yes.
Then how is the conditions? Okay, in which stage it is. It is the granulation tissue, 40% or slough 20%. Like this way we have to mention it, and whether it is the bad odor is there or not, and with the wound condition we have to additionally mention whether the pain is there or not. And around the skin, what is the condition? Means the wounded charpashe je area ta ache, whether it is intact or macerated. Like this way we have to mention. See, there are so many points. Even it is a very common topic, that pressure ulcer wound assessment. So now, after listening her classes, then we need to keep the documentation mentioning all the points to be included. Then actually this nursing leadership in the wound management comes, so that we can prove ourselves the competency. Morning it was discussed, na, why these people are not dependent on the nurse dressing. If the nurse, after seeing the wound, doing the dressing, and she has mentioned all these points, documentation, I think we will have the empower to the dressing. Thank you so much, Richa.
Thank you, ma'am.
Okay. So our next portion, I will go to Chanda. Chanda has very nice experience, long term, I think it is 25 years of experience, and she has done lots of courses and paper presentation, CBTN third position in council 2007. So she is a brilliant nurse. So I will directly go, because nowadays this, if you see in the government sector, this even that surgical diabetics clinic, associated surgical clinic, you will see the many people are coming for the amputations. There is a mixed etiological concern is there, wound management. There are morning session, it is discussed diabetic foot, lower foot wound ulcer. There can be the two reasons. One is the venous insufficiency and second is the peripheral arterial disease. But we may not know always what is the exactly cause. So depending upon the etiological factors, the dressing needs to be selected. So here I would like to request Ms. Chanda, you share your presentation on this point.
Good afternoon to all the audience and all my nursing colleagues present here. Thank you, Madam Kosturi. I'd like to start with a beautiful quotation. That is, one wound, many clues. Choose the dressing, do not just use. A wound may hide more than it shows. Healing begins when assessment grows. Right? So, dressing selection in mixed etiology ulcer, really it's a very key component and we need to keep in mind so many things while we are selecting the dressing for a mixed etiology ulcer. Balancing moisture, perfusion, infection, in complex in really we need to keep it in mind. Before going to the details, we need to know the what is mixed etiology ulcer. It's a ulcer which chronic wound caused by two or more underlying factors. Most commonly chronic venous insufficiency and peripheral arterial disease. That is why their complex nature require careful assessment and individualized management to successful healing. Now, while we are managing such kind of wound and selecting the dressing, so many questions comes in our mind, we are confused. Suppose a wound which is wet but ischemic, should we hydrate? Or a wound which is infected yet poorly perfused, should we compress? Or exudative yet fragile, should we absorb? Or chronic yet biologically active, should we debride aggressively? So it's coming in our mind and we are become confused, and which type of dressing will be best for this wound, that is really a challenge for us. So mixed etiology ulcer, as I said, it is the wound caused by two or more underlying pathologies and requiring careful assessment and a balanced treatment approach. Now, common types of wound are what? If we are talking about mixed etiology ulcer, that is venous and arterial disease type of ulcer. Diabetic pressure injury, obviously very common, and vasculitis, neuropathic ulcer, as well as malignancy associated ulcer. Here the main key challenges we are facing, that is conflicting treatment priorities, impaired tissue perfusion, increased infection risk, delayed wound healing and complex dressing selection. So what we need to know about this, that is wound combination, that we understand first, and regarding that wound combination, which clinical challenges we are commonly faced, that also we are keeping in the mind. If it is venous and arterial type of ulcer, compression therapy may worsen the ischemia. We need to keep it in mind. If it is diabetic and arterial type of wound, high infection risk with poor tissue perfusion. If it is pressure injury, difficult moisture and skin integrity management is a really challenge. And if it is vasculitis and neuropathic wound, delayed inflammatory response and healing is there, and malignant wound, severe odor is there, heavy exudate and pain management is a challenge. So treat the cause, not just the wound. Here are few mixed etiological ulcer example, that is venous stasis. We know if any person is having job like continuous sitting, continuous standing, So they are facing venous stasis, and such kind of ulcer is happening often. We have itching on that type of wound, and afterward it's become a venous stasis dermatitis. Diabetic ulcer is a very common type of mixed etiology ulcer, as well as peripheral arterial disease and venous or arterial insufficiency related ulcer. Before selecting the wound, always we keep it in mind, wound assessment is a very crucial part. Madam Richa has already explained different kind of assessment criteria. I want to highlight the time framework. We need to keep in mind the triangle of wound assessment. That is main three area we need to be very careful. That is wound bed, wound edge and peri-wound skin. If it is coming to the time framework, T for tissue, what we need to do? We need to assess what is the type of tissue, whether it is necrotic, slough, granulation, hypergranulation. These all are the image of those type of tissue necrosis. Coming to the eye infection or inflammation, biofilm, it's a really threat for any complex type of wound management. Then local infection and critical colonization. M for moisture, that is dry wound, moderate exudate or highly exudative wound. And in case of edge advancement, we need to see the undermining, epibloli and non-healing edge. So that area we need to see. Wound assessment is the first component of selecting the appropriate dressing. Now dressing selection core principle. We need to select such kind of dressing which will having this principle. What all that principle? That is maintain moist healing. Moist doesn't mean wet. It should be, the area should be dry, but dry, too much dry wound also having several problems like skin cell migrate poorly, formation of scab, tissue necrotic, tissue necrosis, etc. Next is a protect ischemic tissue. We need to create a shield to protect the vulnerable ischemic tissue from further injury and extreme harm. Control exudate. Too much exudate also is a very much barrier of wound management. So in case of that, manage wound exudate to prevent maceration and support optimum healing. Reduce bioburden, which helps minimize the number of microorganisms in the wound to reduce infection risk. Prevent trauma during removal. It's a very important aspect. We are removing the dressing very aggressively, which create new wound. So we need to keep it in mind while we are removing the dressing material, we need to adequately wet that area and very gently we need to clean the and remove the wound, dressing. Improve patient comfort, which enhance comfort by reducing pain, odor and need for the frequent changes. Now classification, as I already explained, there are various type of mixed etiology ulcer. And so we need to keep in mind key management strategy also. If it is venous and arterial type of ulcer, the main key strategy will be modified compression, edema control, protect ischemic tissue. So which type of dressing will be suitable for such kind of wound? Silicone foam, hydrofiber and super absorbent dressing. If it is diabetic ulcer, diabetic and arterial ulcer type of wound, what will be the key management strategy? That is infection control and glycemic optimization is more essential. So silver dressing, collagen dressing and negative pressure wound therapy is most popular. Pressure injury type of wound, that is pressure redistribution, friction control and skin barrier protection is our ultimate motto. So for that, which type of dressing we will select? Silicone border foam super absorbent dressing. Vasculitic and neuropathic ulcer, that is control of inflammation and protect fragile skin is the main target. So silicone contact layer, hydrogel type of dressing, and malignant wound require palliative wound management, which is also charcoal dressing and silver dressing. So we can see maximum mixed etiology ulcer requires silicone combined super absorbent hydrogel dressing. These all are the few modern categories, traditional versus advanced dressing. Previously, what we are doing, we are selecting the dressing material like gauze dressing, cotton pad, bandage, simple absorbent dressing, It may adhere with the wound bed also, limited moisture control, basic wound protection, it gives basic wound protection and lower initial cost and suitable for simple wound. But in the new advanced era, we need to select such kind of dressing which is foam dressing, hydrocolloid dressing, alliginated dressing, super absorbent dressing, silicone automatic dressing, moisture balancing dressing, antimicrobial dressing, and this is high initial cost in that type of dressing, but improve healing outcome. Few recent advancement in management of mixed etiology ulcer, that is biofilm targeted wound care, which disrupt biofilm to reduce chronic infection and promote healing. Silicone automatic technology also very popular, that is minimize pain and tissue trauma during dressing change. And as I said, I think from morning onward, this negative pressure weight wound therapy type of dressing already explained. Super absorbent polymer dressing also one of the most recent advancement, that is rapid control heavy exudate and prevent maceration. Collagen and biological dressing, that is enhance granulation and support tissue generation, and smart wound monitoring system. Few smart emerging technology in future dressing selection, that is smart dressing with sensor, which will monitor moisture, temperature and infection in real time. AI power assessment tool, nowadays various software is in system, different healthcare organizations are using, which analyze wound data and images automatically uploaded in the system and can give the ideas to manage how to which all type of dressing we can select. Drug releasing dressing, there are dressing material which deliver medication directly to the wound. Bioactive dressing, that is contain bioactive agent, growth factor or cells, and 3D dressing. This 3D type of dressing which is that is customized to fit wound size and shape. Extra dressing is not required, extra wound skin not to be covered, only the area should be covered. Telemedicine and remote monitoring, this is a very important aspect nowadays. It is being used by a different healthcare organization, and here I want to say one more thing. Recently we have implemented a model, that is tele wound care model. Why this tele wound care model? Actually we are facing from the last year surgical site infection, and that also to after discharge, not in house when patient is admitted in the hospital. So we did a root cause analysis, why it's happening after discharge, not inside the hospital, there is no evidence of any infection. So we saw that patient and relative are using very unsterile dressing material, cloth, even if they are applying oil also in the wound. They are not taking any citrus fruits, because it's a myth that this type of fruits will be delay the wound healing. So we did a quality improvement project on that, and we create a wound care video by use of QR code, and that QR code we are applying in a discharge summary of the patient, so that at home also patient relatives can scan the QR code and can have the access how to do a normal dressing aseptically. So that was the idea. Along with that pre-operative shower kit, customized wound care kit, and we also having a specialized software, that is We Care Exam app, where we can patient relative have the access to upload their wound image, and we can have the access to see, and we can guide by that way. Along with that, teleconsultation nurse is there who is doing 90 days surveillance, 30 days, 60 days and 90 days, that is pre-scheduled. So that is working a lot. We are really achieve day by day our SSI rate is decreased. Okay, then nanotechnology based dressing, pH monitoring dressing, automated wound measurement dressing, and EMR integrated wound tracking, also few smart and emerging technologies in this era. Now biofilm, it's a hidden thread really in wound management. What is biofilm? A biofilm is a complex community of microorganisms encased in the protective matrix that attach to the wound surface. How we will understand biofilm occurred in a wound? If we see the slimy and shiny wound surface, recurrent infection despite treatment, delayed or stalled healing, rapid resloughing after debridement, and increased exudate and chronic inflammation, then that means biofilm is developed, and this type of wound management is very difficult. So current management strategy is regular debridement to disrupt the biofilm, targeted antimicrobial therapy, appropriate moisture balancing dressing, ongoing wound assessment and monitoring, and management of underlying cause. This is negative pressure wound therapy. I hope every one of you know. VAC dressing, very popular, different healthcare organization is using for a chronic wound, and we are getting good result as well. The common mistake in dressing selection, what we do, that is choosing dressing based only on the wound appearance, not the underlying cause. Using the same dressing for all wound, inadequate assessment of exudate level, overlooking signs of infection, that is biofilm, and selecting overly occlusive dressing for infected wound, allowing wound to become too dry or too wet. Traumatic dressing removal, as I already said, causing tissue damage. Ignoring patient factor, pain, allergies, mobilities, cost, etc. And inadequate reassessment and delayed dressing changes, failure to address the underlying condition like pressure, ischemia, diabetic, and venous disease. So, the key strategies in selecting dressing, that we need to continuously assess, select the proper dressing, monitor, reassess. If it is required that change to modify the dressing type, then modify, then only successful dressing management will be achieved. Now coming to the nurses' role, we are everywhere, যেমন সর্বঘটে কাঁঠালি কলা, so we have to do something. What is the nurse's role in that? Comprehensive wound assessment, already we have explained. From morning we are discussing how to do a wound assessment. Regular monitoring of healing, appropriate dressing selection, infection prevention and control, pain management, pressure relief and offloading, compression therapy support, patient and caregiver education. So that way, tele-wound care model, I have explained how we need to educate the patient and caregiver, and they are actively participating in all care nowadays. So that is our current objective. And nutritional support, multidisciplinary team coordination. Nurses not only can do the process, multidisciplinary approach require infection surveillance. So I want to conclude my topic that mixed etiology ulcer require individualized dressing selection, etiology assessment more important than product choice. Technology is improving wound care precision, nurses play the central role in wound healing outcome. So the best dressing is not the most expensive one, it is the one matched correctly to the wound physiology. Thank you for listening to me.
So thank you, Swanda. It's very beautifully we have explained the different etiology, and then you have shown that wide range of the dressings which are available and how to adjust with the different types of the wound. Just one thing I would like to add, that when there is the mixed etiology or this chronic wound, if it is pure venous, it's okay, but there will be the combination of the arterial etiology, that is the peripheral arterial disease, along with the venous insufficiency. The one critical points we need to assess, or maybe it has been assessed and kept in the file, we need to find out, that is the ankle brachial complex. This ratios, ABI ratio to amader jante hobe. Normally if it is more than 0.8, so it is the venous insufficiency. If it is 0.5 to 0.8, then there is a mixed etiology. And if it is less than 0.5, it is purely arterial component is there, and it is the very severe form. Why we are discussing it? Because so whenever we are putting the mixed compression, around the compression, what is the pressure and all those things. So normal pressure around the 25 to 30 millimeter of mercury, we can keep the pressure even if it is above the 0.8. But we have to reduce the pressure if it is 0.5 to 0.8, because this further compression will occlude the artery. So it is reduce the nutrition and the blood flow. So that's why during the dressing we have to keep it in mind. even if it is there is a component of the peripheral arterial disease, whenever we are removing the adhesive, as she has mentioned, so once we are removing the adhesive, little bit skin abrasion is there, it will not heal properly because there is always the chances of less blood circulations. So, so how to handle whenever we are doing the dressing? So what are the pitfall or the red flags we can identify or we have to remember during the dressing mixed etiology?
And the answer already you have explained. From my experience, what I understand, that we require comprehensive training on the nurses how to assess the wound and which type of dressing is perfect, and regular assessment and reassessment. What we are doing, once we are doing the dressing is there, and again for if any oozing is visible, then only we'll go for changing and what else. But regular reassessment, the kind of wound assessment and the adequate blood supply is there or not, to see that will be the main target of management. So that is the
another important, thank you Chwanda, another important point, if the patient is complaining of the pain, severely pain, that we have to think there is a certain arterial occlusion is there. It is not maybe due to the wound, it is due to the occlusions. So we have to take care of the wound considering these factors. And we should not apply the compression too much. Negative pressure dressing, that instruments, that equipments can I attach with the mixed etiology? Anybody? Negative pressure wound dressing. Again the same things, if it is the less than 0.5, then we cannot. It is safe, it is totally contraindicated if it is less than 0.5. Only we can assess, apply it if it is more than 0.5. Okay, so thank you. Next portion I will go to Minoti, and Minoti also has a very wide range of experience. I think 17 years she is doing the MBA also. As morning session, we know that physical wound can create the psychological wound. So that needs that we need to take care of the wound and the scar management. Okay. So how we will do the scar management, Minoti will highlight.
We discuss a lot about the wound and wound care management, and all of us, we had our post lunch. So our mesenteric circulation is that this much too high, too much active. So I don't want to disturb that too much. So I want to discuss here some few points. Especially on cosmesis of wound scar, I want to emphasize on that. First, I want to discuss the cosmesis definition. The cosmesis of a heel wound has a fully closed the scar, well integrates with the surrounding tissue in color, textures, and contour. A good cosmesis means the scar is minimally visible and does not significantly distract from the natural appearance. Learning objective. The learning objectives are as follows: to understand the physiology of wound healing and scar formation, assess the scarred tissue using evidence-based frameworks and tools, apply non-pharmacological and advanced therapeutic intervention, integrate pharmacological management into holistic wound care. Types of scar: hypertrophic scar, that is raised, confined to the wound. Keloid scar, extend the wound borders. Atrophic scar, sunscreen or depress. As a nursing staff and our daily activities, I hope all of us, we know this, and we are from the beginning, we can detect this. So for that early management of this scar wound. Here are the two pictures, hypertrophic scar and the keloids. The impact of scar formation, how it is formed. The physiologic scar, this fades from over time but never reaches the exact tensile strength or appearance of original skin. Hypertrophic scar, it is raised, red and confined with the wound boundaries of the original wound. Keloid extubent scar tissue extending beyond the original wound margins. Cosmetic defects, wound dehiscence, infection and pore edge. The biology of healing. The inflammatory phase, it takes 0 to 3 days. It is hemostasis and leukocytes migration. Proliferative phase, it takes 3 to 21 days. It's collagen disposition here and by fibroblast and epithelialization. Remodeling phase, it will take 21 to 2 years. Here collagen maturation which dictates the tensile strength and appearance. Phases of healing, save the hemostasis, already I discussed immediate, which we have to find out immediate. There is vasoconstriction and platelet aggression and fibrin clot formation. Inflammation, number 2, it will take days 1 to 2. This is vasodilatation, neutrophil and infiltration, so to clear debris and macrophage recruitment. Number 3, proliferation, it will take days 4 to 21. Fibroblast proliferation and angiogenesis and collagen synthesis. Number 4, remodeling. Remodeling means maturation of collagen. It takes weeks to years. Collagen breaks down here and synthesis shift, increasing tensile strength. Now stages of wound healing. Bleeding, inflammatory, proliferation and remodeling, what previously I discussed. Here I want to point out some point we should know the did not heal rule. Because in our nursing experience, we mostly observe whenever we get patient come to us mostly in their late stage. So early diagnosis and mostly early observation, not only for the nursing or medical person, it's for the part of the health teaching of patient, for the patient relative, because in our 6th NABH education, it is emphasis on the patient's and family education mostly. So the did not rule is like that. The first D is diabetes. Diabetes impair neutrophil function and peripheral perfusion. Next, I, infection, prolong inflammation, destroy new formed tissue. Next, D, drug, steroid and chemotherapy inhibits collagen synthesis and fibroblast proliferation. Nutritional deficiency, lack of vitamin C, what my colleague Chandra already mentioned. We all observe that whenever patient come to us with a wound, when we take their nutrition history, there are lack of citrus fruit or vitamin C deficiency we observe. So we have to give that health education also. So nutritional deficiency, lack of vitamin C prevents stable collagen production, protein deficiency impaired tissue growth. Tissue ischemia, poor blood supply leads to necrosis. Now wound care, we will discuss the wound care principle, how we, this principle we should follow. First, as a nursing staff, we all know daily basis, we are doing our in 24/3 shift hours and we monitoring these clean wound daily with saline, apply moisturizer, apply sterile dressing gauze, highlight hydration, apply emollients to prevent dryness, because too much dryness is not the right thing for the good healing. And protect from tension across the wound side, means too much tight dressing is not good for the wound healing. Now medical assessment scale. Generally there are two scales to assess the wound. The clinician evaluate the success of wound cosmesis using standardized scoring tools to track healing and measure patient satisfaction. The first scale, the SCAR scale, SCAR cosmesis assessment and rating, a highly efficient 20-second clinical tool it is. It rates 6 objective observer criteria: scar spread, redness, erythema, dyspigmentation, suture marks, hypertrophy, atrophy, and overall impression, alongside 2 patient impression also, patient reported system. Patient experienced itching, stiffness, pain. The scale, that is patient and observer scar assessment scale. A comprehensive dual part system. One is the practitioner, what the practitioner observed, and one is the what the patient experienced. The practitioners means clinician rates physical features like vascularity, pigmentation, and thickness. And the patient, what patient experienced, patient rates subjective symptoms like stiffness, color changes, redness, discomfort, and the stiffness. The Vancouver scar scale, another scale is VSS. That it is one of the oldest objective metrics, focusing strictly on clinician and observed physical trait. Scar management and prevention. The most popular is the silicone gel sheeting. It prevents to hydrate the skull and modulate fibroblast activity, flattening raised scar. Pressure therapy. Custom compression garments used to prevent hypertrophic scar. That is common, very common in for the post-burns cases. And next is the what we also, especially female also use this, the sun protection. UV rays stimulate melanocytes in new scar, causing permanent darkening, hyperpigmentation. So advise stick SPF uses for 6 to 12 months. Goal of the scar healed. Primary objective is restore both function and aesthetics while minimizing visible scarring. Cosmesis definition, the prevention, restoration, and best possible appearance of bodily features. Key influence, wound tension, blood supply, genetic predisposition, and surgical. The treatment option. First, what I previously discussed, apply silicone sheet to reduce redness and flatten scar, pressure therapy especially for post-surgical and burn scar, and laser therapy is at the same time most popular to improve the color and the texture, especially the scar wound, keloid wound. Now, wound preparation for optimal cosmesis. First, debridement, removal of devitalized tissue and foreign bodies to prevent infection and inflammation. Next, irrigation. High pressure saline irrigation flushes bacteria without damaging our healthy and delicate tissue. Next, hemostasis. Strict control of bleeding prevents hematomas which separate wound edge and invite bacteria. Treatment option, silicone provide occlusion and hydration to the wound, which allows the new and underdeveloped stratum corneum to retain more water, because hydration is the most important part which heal the wound scar, thereby reducing amount of collagen produced in the affected region. Importantly, the hydration provided by silicone resembles that of normal skin, thereby normalizing the stratum cornea, preventing any detrimental effects that can be associated with an excessively moist barrier. A clinical trial showing that silicone sheet reduced scar width by 30% in a month. Silicone sheet flatten and soften the scar and almost make it a flawless condition. Pressure therapy is important for burns and surgical scar, hypertrophic scar. Laser treatment improve pigmentation and texture. See here, we use the Texas silicone, which is the most helpful for the scar wound. The science of silicon scar type, how does it work? Several clinical trials have demonstrated that silicon scar tape effectively reduce the appearance of hypertrophic and keloid scar. When applied for prolonged periods, silicon scar tape is particularly effective in reducing scar thickness, redness, and pain. As a result, silicon-based therapies are considered the first line and standard treatment for scar. Here we can see before how was the scar, and after applying the silicone, it's almost invisible, almost the flat in the scar. Advanced scar treatment modalities. Laser treatment, how it was the pulse dye laser, what is PDL, and fractional CO2, ND, YAZ, and XIMR. Mechanism, collagen remodeling, vascularity reduction, and pigmentation correction. Injectable solution, corticosteroid, 5-fluorouracil, what is 5-FU, and bleomycin. Botulinum toxin, mechanism, anti-inflammatory. All these are anti-inflammatory, collagenous activation, and tension reduction. Procedural approaches, chemical peels. Already my colleague Chanda is showing us too many dressing peels. Chemical peel, Darbar precision, subcision, and punch excise. Mechanism, tissue resurfacing, mechanical disruption, and re-epithelialization. Biologic and newer. Regenerative practice, stem cell therapy, and platelet-rich plasma, growth factors. Mechanism, cellular signaling, collagen organization, and tissue regeneration. Here another scar before and after. There are some non-pharmacological intervention. Pressure garments, its graduate compression to reduce collagen deposition on 12 to 12 hours per day for 6 to 12 months. And silicone products, gel sheet or ointment, hydrate skin and modulate collagen synthesis, 12 hours per day daily. It have to use massage and mobilization, soft tissue mobilization to improve pliability and reduce stiffness, safe after epithelialization. Laser therapy, pulse dye or fractional CO2 target vascularity and stimulate remodeling. Microneedling, control skin injury to stimulate collagen reorganization and neovascularization. Cryotherapy, cold therapy reduce vascularity in hypertrophic and keloid scar. Now we have some evidence-based assessment tool. What the my previous slide I discussed this patient and observer scar scale assessment. Observer, what observer assess? Vascularity, pigmentation, thickness, relief and contour. That is the part of the clinician. And what patient give the rates? Patient can feel pain, itching, color and stiffness. Another Vancouver scar scale, vascularity 0-3, normal, pink, red, purple, all these are assessed. Pigmentation 0 to 2 days, normal, hypo, hyperscar, and pliability 0 to 5, normal to contracture, and height 0 to 3, it is flat or raised. Evidence-based practice guidelines. All these guidelines we can achieve from American Academy of Dermatology, multimodal approach recommendation and pressure garment, level B evidence, laser, injectable combination for optimal result, international scar management guidelines. This is the early intervention within 3 to 6 months optimal. POSS and VAS for standardization assessment and combination therapy prefer. Wound Healing Society, WHS, that is prevention through tension management during healing, that is Langer's Linus, consideration during closure, early pressure and silicone use. American Burn Association, pressure garments 12 to 12 hours per day we have to use. Laser beginning 6 to 8 weeks post injury, injectable after 3 months minimum. The importance of early management. Early intervention like silicone shield or massage can prevent excessive collagen production, reducing the risk of hypertrophy or keloids formation. Key takeaway and summary. Comprehensive assessment using POSS and VSS enabled objective scar monitoring. Number 2, multimodular treatment, that is pressure, silicone, massage, injectable, laser yields best outcome. Number 3, early intervention, that is the most important part of our job. Within 3 to 6 months, you can do this, and complaints are critically success factor. The most important is patient and patient-related education, and psychological support are integral part to wound care. Evidence-based guidelines inform practice, individualized care to patient context. Recommendation: early scar assessment during wound care, educate patient on daily moisturizing and UV protection, ensure follow-up visit to monitor progress, ensure patient by maintaining a structural approach to improve both functional and aesthetics outcomes. Thank you. Thank you for your patience.
Thank you, Minoti. She has told in depth how to manage the scar. Basically, she has mostly focused how to prevent the scar formations. So we have seen that scar management starts before the epithelial cells grows, and it extends well into the remodeling phase. So from the sessions, we thank you, Minoti, take your seat. So from these 2 days, these sessions, we can identify that nurses has to work with the directly wound assessment to total scar management. Yes? So all of us are well equipped with the concept or the cognitive information which is required to deal the wound. But at the bedside, when the nurses are working, or we are working, so it is the 5% of the work or the less than 5% of the work. Yes or no? How nurse can provide whatever we have been taught, only things if the nurse and the patient ratio has been improved, then only it is possible to provide this type of optimum care. Yes? Because these nurses, their workload not only to the clinical duties, which the other people, other professionals are expecting that they will do the vital status, hemodynamic adjustment, all those things, administration of IV medications, fluids, everything. This is, again, this is the 30%. Where the rest of the part is going? The rest of the part is going the invisible labor. What is invisible labor? Searching housekeeping staff, searching the in charge for escalating, searching the doctors, okay? Coordinating, bringing the trolley, sending patients, searching for the bed, transferring the patient from one department to another department. It is not where, nowhere is documenting. Nurses are documenting everything. What nurses are doing, no one is getting the documentation. So why I am telling, because all those things, we are taking the wound care of the patients. If we are not taking care of your mind, health, body, then we will have the psychological wound, emotional wound, that is the burnout. Okay? So whenever we are take care of the wound of the others patient, we have to take care of ourselves. Physical, mental, and the psychological. Sometimes we hurt, and we used to tell also that we do not have time. But these professions, even if we shout nurse-patient ratio, coming 10 years, again it will be less. So even if we are shouting, it doesn't help us. One thing is that we have to develop our resiliency, our certain voice areas, we have to see. একদম সত্য কথা কি মা বাচ্চা যদি না কাঁদে মাও কিন্তু ব্রেস্ট ফিডিং করায় না ওকে সো নট অলওয়েজ ক্রাইং এগেন মাদার উইল ইগনোর বাট ঠিক টাইমে ক্রাইংটাও কিন্তু দরকার ফর হ্যাভিং দ্য গুড ব্রেস্ট ফিডিং সো we will take care of the wound of the others, no doubt it is. We can implement it. The basic things is that our workload, we are, মানে এটা একটা আমাদের বাধা সৃষ্টি করছে. Anyway, still আমাদেরকে এই চ্যালেঞ্জটা ফেস করতে হবে, and we have to prove that we are competent, we can manage the wound, we can do the dressings, because we have to prove the competency. The one thing is that আমাদের proper documentation টা করতে হবে. Whatever we are assessing with our eyes, the wound, we have to prove it with the documentation. And when the doctors are coming for a round and they are seeing that we have assessed the wound, we are writing like this way. Not only writing এ একজনের copy করে রেখে দেবে. We have to verbalize it. Then, obviously, next, within a 3 days, they will depend on us. কোথাও একটা আমাদের গ্যাপ থেকে যাচ্ছে এবং সবটার মধ্যে ম্যাডামও you have discussed the nurse patient ratio, actually it is the culprit. Thank you so much. We are ending the session.
Thank you, ma'am. I request Avanti ma'am once again to please be on the dais to present mementos to the chairperson and the speakers. To Ms. Chanda Bandopadhyay. To Ms. Minoti Hajra. To Ms. Richa Nemira Pakkam. Nemira. And to our chairperson of the session, Ms. Kasturi Mandal. I request also once again for a group photographer to please be on the dais. Thank you. The QIP session is on the other side of the hall. So if you're interested, you please join on the QIP session, or you may visit the stall. So the session in this side of the hall is over. Thank you.
A very good afternoon to all of you. Really, the session was very good. Isn't it, Jonna?
Yes, yes.
So, but we have excluded Madam Dolly Vicious because she has already told her interest of presenting that part. So, we didn't evaluate Madam Dolly Vicious. At the same time, we didn't evaluate Madam Sravani Christian also because it was not a QIP. We have listened, it was a very good presentation, but as per the criteria guidelines, we couldn't able to give the marks, so we have excluded you also from this competition. So now, the third from our evaluation, it was Miss Joyashree Pal, Chief Nursing Superintendent from Eastern Railway Hospital, Lilua, Howrah. She has presented a descriptive study to assess the knowledge and practice on menstrual hygiene, complementary and alternative therapy in menstrual problems among nursing students. Give me a second.
Next, I am announcing the Second prize goes to Track, Assess and Protect, a nursing lead initiative to prevent pressure injuries through risk-based intervention and evidence-based dressing use. Swayambhu Chandana, nursing officer from Apollo Multi-Speciality Hospital.
Very nice presentation. And the first prize goes to whom? Mrs. Suparna Giri, Educated Senior Nurse Executive, Fearless Hospital. She has presented on enhancing skin integrity, reducing MRSA and DAPI incidents through evidence-based nursing intervention. Nice presentation it was.
So thank you all the presenter. So nice presentation and we have enjoyed. No. Okay, madam. Okay, madam. So for the efforts, and definitely it was also a nice presentation. So 2 more participants who will get the token of appreciation from this nursing conclave. They are Mrs. Sabuni Christian and Mrs. Krishna Kumar V. And Mrs. Shumita Bhattacharya. দুজন কথা মোর সিস্টার তিনজন আছে এটা হতে পারে দল থেকে রাখো এই ডলি দি একটুখানি চলে ম্যাম দিয়ে দিকে ডলি দি ডলি ব্যাস তাহলে সবার হয়ে গেছে
I request Dolly ma'am to present mementos to the juries also.
Ma'am, I request you to present goodie bags to the observer ma'ams also. Miss Madhuri Manna and Miss Ashmita Mukherjee, please be on the dais. Thank you. I request all the participants to please visit the stalls for Skillathon. Thank you all for joining us today. Please visit the stalls for Skillathon. Please visit DD Healthcare stall, Arjo Huntlet, Smith and Nephew, Coloplast and Convatec for Skillathon.